हेलो, अभी लाइव कर दिया आपने? ये तो लाइव हुआ नहीं है। मैं हूँ। मेरे को तो मैं नहीं नज़र आ रही हूँ। हो रहा है। अच्छा, ओके। ठीक, ओके. So now starting with good morning everyone. So let's start with all the OBGY images. This will gonna be a short session, maybe of around 2.5 hours. We'll revise all the images that will be discussed. Since NEET PG is very close by, we'll be how we'll go about with it. We'll go topic wise. Okay, each topic wise we will, yeah. So each topic wise we'll be going for the images, and then any related topic, any related question, that new question and any old question that can be asked based on that image, that we will gonna cover. Okay, starting with the physiological changes in pregnancy. Now I have always said that pregnancy is a condition where every cell of your body undergoes changes, everything changes. So starting with the skin changes. So what happened in pregnancy is that suddenly the MSH, melanocyte stimulating hormone, levels start increasing. That is why there is darkening at everywhere. Darkening of the abdomen, darkening of nipple areola complex, and many other places. Can you tell me the name of this sign? The central line. The central line that comes in pregnancy, remember, it is linea nigra. Remember that it is not linea alba. See, alba matlab albinism, it is white. ठीक है, वहीं से that albinism word has come, it is white. Linea nigra, so take image. Linea nigra is means dark. So linea nigra is the dark line that comes up in pregnancy. So don't mark linea alba. Linea alba is present in everyone. It is very prominent in children. Okay, can you also see these? These are what? These are stretch marks called as stria gravidarum. It is basically the collagen tissue that has separated during the uterine enlargement, that is giving rise to stria gravidarum. So these are the two skin changes. What is important to remember is that these changes don't come very early. These come at around 24 to 28 weeks. So at around 24 to 28 weeks, these skin changes start appearing. Now, along with this, darkening also happen at malar eminences. This is called as pregnancy mark, also called as chloasma. Chloasma or pregnancy mask, because of increased MSH, melanocyte stimulating hormone. This also starts at around 24 to 28 weeks. If question asks, what is the treatment of this condition? Nothing. You have to reassure women. You have to give nothing, because it is a condition that will resolve once the pregnancy is over. So treatment is reassurance. Okay? This one, what is this? So this is a very common image. I know you all must be knowing the answer. The answer to this is supine hypotension. Good, congratulations. Very good, Gyanendra. Supine hypotension syndrome. Supine hypotension syndrome means when the woman is lying down, when she is lying down, her vessel is compressed. As a result, she feels dizzy. Question number 1, which vessel is compressed? Inferior vena cava is the one which compress. Question number 2, this sign appear at what gestation? See, uterus has to be enlarged enough, uterus has to be heavy enough to compress this huge vessel. So it appears at 28 weeks. Uterus is so huge at 28 weeks that it compresses the large vessel, and she becomes hypotensive when she lies down. So what will you tell her when she is dizzy while lying down? You will tell her to lie in left lateral position. By lying in left lateral position, question number 3, how much cardiac output will increase? Cardiac output will rise by around 10%. As soon as she'll turn to her left, the pressure is relieved, the cardiac output will rise by 10%. Just give me a second. I think I should need to reduce my own size. That is blocking a lot of images. Hai na? Yes, now it is better. Okay, so this is supine hypotension syndrome. Condition number 3rd. Now, these are the levels of hormonal changes that can happen in pregnancy. So, can you tell me what is this pink graph? What is this pink graph that is peaking at around 8 to 10 weeks? So, this hormone is peaking at around 8 to 10 weeks. Okay? Yeah, now it is okay, no? It is peaking at around 8 to... and then it is falling significantly after peaking at 8 to 10 weeks. And let me tell you, the level at this 8 to 10 weeks is around 1 lakh. What is this hormone? Can someone tell me what is this hormone? This pink hormone, what is it? What is this pink hormone, kids? Chalo, koi baat nahi. It is HCG hormone. It is the HCG hormone that is basically peaking at 8 to 10 weeks and then finally it falls. So why this falls? Because there is a very significant change that happens at 8 to 10 weeks, and that is luteoplacental shift. Luteoplacental shift happen means we don't need corpus luteum anymore. We have placenta now, so we don't need corpus luteum, and hence we don't need HCG. That is why it falls. Second hormone, can you see these blue color hormones that are rising with pregnancy? Slowly they are rising, and as soon as the patient delivers, they are significantly falling. They fall into a very low levels as soon as the patient delivers. These blue color hormones, they are estrogen and progesterone. Okay? They are rising with pregnancy and they fall as soon as the woman delivers. Now another hormone on which question has been asked in NEET 2021, this purple color hormone, it is again rising with pregnancy, maximum at around birth, and now after birth it falls, but not to a very significant level. It is a hormone that we need even after delivery, and as soon as the baby starts feeding, it peaks. There are peaks which are seen with each sucking. It is prolactin hormone. It is prolactin hormone that is peaking with each delivery, with each sucking process. Okay? I hope my video is clear to everyone now. Is it? I hope the audio and the video are not stucking now. Okay? So this is prolactin hormone that has been questioned in NEET PG 2021. Now pelvic signs, very frequently question has been asked. Let's quickly see and please keep answering. What is this pelvic sign? So there are in pregnancy, there are 6 pelvic signs that are seen. 6 pelvic signs are seen in pregnancy. Can you tell me what is this bluish discoloration of cervix and vulva vagina? What is this bluish discoloration of cervix and vulva vagina? It is Chadwick sign. Chadwick or Jacquemer sign is when the bluish discoloration happen of cervix, vulva and vagina. Okay? All of them become bluish. Then what is this sign? This, when my hand, one vaginally and one abdominally, trying to approximate each other. What is this sign? It is Hagar sign. Just like letter H, my 2 hands are trying to approximate, and they can approximate in between, not above because baby is implanted there. They can't approximate below because of the cervix, but they can approximate in middle because of softening of that part. That is Hagar sign, like letter H. Okay? Next, bimanual examination again, and I'm trying to grip the uterus, and when I'm trying to hold the uterus in my palms, so remember by that name, if I'm trying to hold the uterus in my palms, I can feel pulsation. So pulsation felt on bimanual examination. What is this? Palmer sign. There are other 2 signs on which images can't be asked, and that is a soft cervix. A soft cervix is a very good cervix, hence the name is Goodell sign. A good cervix means a soft cervix, and hence the Goodell sign. Okay? Keep answering. See, if you'll keep answering, it will be like a revision for you all, and you'll stay more active. So just don't listen, just keep answering. Right? What is happening to the screen? Now it is going down. I think it is too much. Oh. Feeling so embarrassed of all the disturbance that is going on constantly, and I'm sorry for that. Bas. Now I think it is adjusted. I think now the screen is visible. That's what I feel. Now the screen is also corrected. This was that we have discussed Chadwick sign, then H, letter H से याद रखते हैं, letter H से Higard sign. ठीक है, what is this? This is your Palmer sign. ठीक है, remember now this is not image based, but a soft cervix is very good cervix, so it is Goodell sign. ठीक है, on keeping my finger in the fornix means near the os. That is how I used to remember. If I keep my finger near the os in the fornix, I can feel pulsation of uterine artery. So where am I keeping my finger? Near os. Hence the name Osiander sign. ठीक है. Now next image. Can you see the two types of GSAC? Now question number 1. The earliest sign of pregnancy. What is the earliest sign of pregnancy on ultrasound? What is the earliest sign? That is GSAC. But remember, GSAC is not a confirmatory sign of intrauterine pregnancy. So the confirmatory sign that the pregnancy is intrauterine. Confirmatory sign of an intrauterine pregnancy is when we see a yolk sac. Yolk sac is a confirmatory sign that the pregnancy is inside the uterus, not GSAC. Why? Because there is also an entity named as pseudo-GSAC. So pseudo-GSAC is there, which happen in ectopic pregnancy. That is why just seeing GSAC doesn't mean the pregnancy is inside the uterus. Can I not differentiate between these two? I can. If the image is asked, you can easily differentiate. See, pseudo-GSAC is never circular. It's a water droplet. So depending on how much pressure you are giving on the probe, the shape changes. So it is not round, it is irregular, and the shape is not fixed. The shape keeps on changing depending on my probe pressure. Whereas a true GSAC is round, it is regular. Okay? And can you see the two decidua? One decidua is this and another one is this. Two decidua are covering this GSAC. So there is a double decidual sac sign. But here I can't see decidua. I can't see any white line around it. So there is no double decidual sac sign. Okay? So based on these you can differentiate. There is also called as double bleb sign, but whenever an image will be given, these image will be given. Okay? Double bleb sign is positive. What is double bleb sign? When a GSAC and yolk sac both are present, they look like double bleb. That are positive in true GSAC, but that's not positive in a ectopic pregnancy. Double bleb sign is not there. Okay? What is this? So we started with physiological changes. Now we are coming slowly to the early changes in pregnancy, the early screening in pregnancy. What is this? This is nuchal translucency. इसको हम बोलते हैं level 1 scan. Level 1 scan is done for which pathology? It is done for aneuploidy. Remember, level 1 scan, this scan is not done for neural tube defect. It is done for aneuploidies. What am I measuring? I am measuring this nuchal thickness. The thickness of my nuchal fold. So the nuchal thickness, if it is more than 3 mm, it is positive screening test. This is a screening test for aneuploidy. So this raises a question. In first trimester, what screening tests are done for aneuploidy? One is level 1 scan. Can anybody else tell me what another test you do in first trimester for aneuploidy screening? You do both of them. You do ultrasound also, you do this blood test also. Which blood test is done in first trimester for aneuploidy screening? Which blood test is done? And also tell me about second trimester. Which blood test will be done, please? Please, we are subah. Why are you so lazy? Just answer. I know there have been so many technical issues, but now they are not. So just answer. What blood test is done in first trimester for aneuploidy screening? No answer? I'm waiting. What is that marker that is done in first trimester? Right, dual marker. Dual marker is the blood test that is done for aneuploidy screening in first trimester. So first trimester mein aneuploidy screening is done by two ways. One is this nuchal translucency, another one is dual marker. In second trimester now we can't do nuchal translucency. Nuchal translucency can only be done in first trimester. So if a patient has missed the first trimester screening, in second trimester I can only do the blood test, which is the quadruple test. Only quadruple test can be done. Okay. Right? Okay, quadruple test is done. Triple marker is almost obsolete now, but yes, triple marker was a test which was initially done in case of second trimester screening, but हम quadruple test करते हैं. Now, do you all of you know? I hope all of you know the markers, the blood markers that has to be done. That I don't want to discuss. But what I want to discuss is what changes happen. In case a question comes, alpha fetoprotein is low, estradiol is high, what is the diagnosis? Will you be able to make diagnosis? So you just need to know the marker changes that happen in aneuploidy. So I have a mnemonic for that. What happens in Down syndrome? To various markers, what happens in Down syndrome? In Down syndrome, remember, high is high. High is high, means CG is high, inhibin is high, but it is zooming. Why it has zoomed? SCG is high, inhibin is high, and rest two are falling. Okay? So HCG and inhibin are high and rest alpha fetoprotein and estradiol are low in a Down syndrome patient. What about Turner syndrome? In Turner syndrome, high is very high. So remember, high is very high. It means HCG is very high. Inhibin is very high. Okay? And alpha fetoprotein and estradiol are low. Okay? What about Edwards syndrome? See, Edward is a name of a boy, isn't it? Edward is the name of the boy. So what happened in Edwards syndrome is, because he is a boy, he is low. He is low, why? Because he is suffering from Edwards syndrome. So he is low. HCG is low, estradiol is low. Rest two are normal. Okay, so he is low. HCG and estradiol are low, rest two are normal in Edwards syndrome. Okay? What happened in Patau syndrome? In Patau syndrome, there is P, isn't it? There is P in Patau syndrome. So alpha fetoprotein is high, rest all are normal. So through this mnemonic, you can remember what hormonal changes are happening in different kinds of aneuploidies. Okay? Cool? Next image. So once the screening is positive, now we have learned about the screening test. Once the screening is positive, we go for diagnostic test. So diagnostic test with the images based questions will be asked. So this is diagnostic test. If I'll zoom it, can you tell me what diagnostic test is this one? What diagnostic test is this one? Voice problem? Is everyone having the voice problem? Is everyone having this voice problem? Hello? I think the voice is okay. What is this confirmatory test? What is this confirmatory diagnostic test? A vaginal catheter is going into the placenta. So what is this test that is being taken place here? What is this test? It is a diagnostic test for aneuploidy. It is chorionic villus sampling. Okay, since I am going into chorionic villi, it is chorionic villus sampling, and chorionic villus sampling is done at 11 to 14 weeks. Remember, chorionic villus sampling can be done vaginally and abdominally also. Abdominally bhi kar sakte hain. So in case you see an abdominal needle going into placenta, don't think it is amniocentesis. Amniocentesis mein you will clearly see a needle going into the amniotic cavity. Okay? A needle will be going into the amniotic cavity, that is amniocentesis. So chorionic villus sampling can be done abdominally also. You might get an image where abdominal needle is reaching the placenta. So this is amniocentesis, where the needle is sucking the fluid from amniotic cavity. And amniocentesis has to be done at 15 to 20 weeks. It is a confirmatory test but done in second trimester. Okay? Third, this one. Can you see a needle going into the umbilical cord? So this is chordocentesis. Though not very well used for confirmatory test, chordocentesis is basically used in Rh negative pregnancy. But you should know the image. Chordocentesis, when the needle is going into the umbilical cord, it is done beyond 15 weeks. The cord should be thick enough so that I can insert a needle. So it has to be done in second trimester only, after 15 weeks. Okay? So this was all about the early antenatal care. I hope you understood that chart where how hormonal changes happen in each aneuploidy. You have got that. Now we can come to early pregnancy complications. This is a very beautiful diagram explaining the types of spontaneous abortions. Now just listen very, very carefully. So please listen, be very focused when I'm explaining these kind of spontaneous abortions. If a question gives you, patient has bleeding, can you see the os? The os is closed, and if I do ultrasound, can you see it's a beautiful baby lying inside? So fetal heart is present, the baby is healthy, patient is bleeding, but os is closed. This is threatened abortion. Abortion has not happened yet, but the uterus is threatening you. It is threatened abortion. Okay? Uterus is threatening you that it might abort. Okay? What is this? When the os is open, patient is bleeding but os has got opened, though the G-sac is fine, the fetal heart is fine, but os is open, I can't stop this abortion process. When the os is open, abortion will happen. So it is inevitable abortion. I can't prevent it, it is inevitable when the os is open. Third situation, os is open but there is no G-sac on ultrasound. What I feel is only some products of conception, only some tissue in vagina and uterus. It means abortion has happened. Most likely it is the placental mass left behind. So it is incomplete abortion. The baby has come out, only some placental tissue is left behind. This is incomplete. Okay? Question number 4. Patient has come to you with bleeding, os is closed. So you became happy, os is closed, but when you did ultrasound, there was nothing inside. The cavity was empty. So it is complete abortion. Abortion happened sometime through the bleeding and now it is complete. It is complete abortion. Situation number 5. Os is closed, patient has not been bleeding. Patient has just come to you for routine scan. But you realize the baby is gone, baby is non-viable. That is missed abortion. How will you know that the baby is not viable? What are the signs telling you that it is a missed abortion? There is a G-sac of 25 mm. 25 mm matlab 2.5 centimeter. This big G-sac is there, but there is no embryonic pole. G-sac is so big, but there is no embryonic pole. It means you don't need to repeat the scan. It is a missed abortion. Or the baby is there with crown rump length of almost 7 mm, but no fetal heart. So there has to be a level, no? Once fetal heart is not there, you generally repeat the ultrasound, but there has to be a threshold. If crown rump length is 7 mm, still no fetal heart, it is missed abortion. There is no use of keep repeating the ultrasound. Okay? So these are the types of spontaneous abortion which you can judge by the image. What is this? So in case of recurrent pregnancy loss, one cause is incompetent cervix. Incompetent cervix, remember, is a clinical diagnosis. It's clinical. I can't diagnose it without a clinical history. A woman has a history of previous mid-trimester abortion. A woman has history of preterm. When I did ultrasound, the cervix was short. So clinical plus ultrasound. I need both. I need history and ultrasound both. That diagnose incompetent cervix. And what is this procedure being done here? This one, it is cerclage. And if someone especially asks, what is this cerclage? Which one is this cerclage? It is McDonald cerclage done vaginally. It is McDonald cerclage. Okay? Now comes abortion. Now let's see certain instruments used for induced abortion. Induced abortion. What is this? It is a manual vacuum aspiration syringe. It is an MVA syringe, specifically important, used only for first trimester abortion. MVA syringe is not used for second trimester abortion. Then it is of two types. Can you see two valves? It is two valves and bivalve, univalve. Okay? And MVA syringe ka good thing is there is no use of a suction pump. We manually create the pump. Manually we do the pumping. So there is no electricity needed. And I can very well use it in the peripheries. But important, it is used only for first trimester surgical abortions. Okay? What is this? This is used for second trimester abortion. The second trimester may the baby is big enough. Now the baby will be growing limbs, hands and feet. So if I want to do the abortion, I need something to pull the baby out. I can't suck it. Okay? So this is ovum forceps. So see, can you see the anterior end? This is like a cup. So it is ovum forceps. Ovum forceps does not has a latch, the lock. The lock is not there in ovum forceps. Okay? So ovum forceps is used for second trimester abortions. Okay? It is used for what? It is used for second trimester abortions. Okay? What is this? This is Kärman's cannula. Kärman's cannula are attached to the suction pump. Okay? Can you see these ends? These colored ends are of different diameters, used for different gestation. So each gestation has a different diameter that has to be used. So here we attach the cannula, here we attach the suction pump. So Kärman's cannula are used for electrical suction pump. Used for electrical suction. They can be used in first and second trimester both. You can use in both the abortions. First maybe and second maybe. Okay? So after abortions, what is this? Please be active, bacho. If you are not active, how will I know you are even listening? What is this? What I am showing you right now. Tell me the sign and tell me the diagnosis. Both. Tell me the name of this sign and tell me the diagnosis which is there. You have to tell me both. What is this? Your exams are very close by, so I hope all of you know this. What is this sign and what is the diagnosis that has been made by seeing this sign? Anybody? Write the short form. You don't need to write the full form. What is this sign? Anybody? What is this sign? None? Ring of fire. Can I see a fire like a ring? It is ring of fire sign. Seen in case of ectopic pregnancy. This pregnancy is lying in the adnexa and it is receiving so much of blood that it is looking like a ring. So ring of fire sign seen in case of ectopic pregnancy. Okay, ectopic pregnancy is diagnosed based on ultrasound only. So ectopic pregnancy ke liye the diagnostic test is ultrasound. So when I see ring of fire sign, when I see an adnexal mass, that is ectopic. When ultrasound was not available, in our days when ultrasound was not that freely available everywhere, that time to diagnose the rupture ectopic, अगर हमें rupture ectopic diagnose करना होता था, that time we had no ultrasound in emergencies. We used to use this. This is what? Culdocentesis. Culdocentesis मतलब from the pouch of Douglas, from the Culdi sac, I'm trying to suck something. I'm trying to suck out something. That is culdocentesis. See, when a woman is standing, if there is a rupture ectopic, all the blood will collect in the most dependent area. The most dependent area is that pouch of Douglas, that cul-de-sac. That is the most dependent area. है ना? So if I can suck out blood from that part, it means it is ruptured. So cultocentesis is this procedure, if I can zoom, where a needle is inserted into the pouch of Douglas. It is done for ectopic pregnancy, and sometimes it is also done for pelvic abscess. If there is a pelvic abscess, that can also be diagnosed using cultocentesis. Okay? Now coming to other early pregnancy complication, the molar pregnancy. Which type of mole this is? When I can only see the vesicles, nothing else, only the vesicles are visible, it is complete mole. When along with vesicular changes, I can also see a baby, then it is partial mole. Both of them are benign but pre-malignant. It is diploid, but it is androgenic. Means all the chromosomes are coming from the father. It can be XX, it can be XY, it can also be YY. Okay, it is diploid and androgenic. Partial mole is triploid. The chromosomes are coming from father and mother both, but it is triploid. Okay? Snowstorm appearance. So what is used for diagnosis? So diagnosis के लिए first we use ultrasound, but the confirmatory diagnosis. Remember the molar का confirmatory diagnosis is by, how do I confirm the diagnosis? By histopath. Ultrasound is a modality that can help you in diagnosis. So what do you see in ultrasound? In ultrasound, I'll see something like this. What is this? This is a snowstorm appearance. This is a snowstorm appearance. Also, one more thing is given, this. So in complete mole especially, what we see is enlarged ovaries. Why these ovaries are so enlarged? Theca lutein cyst. They are so enlarged because of which hormone? HCG is so high that it is stimulating the ovary, resulting in a theca lutein cyst. So theca lutein cyst and snowstorm both are seen in complete mole. What is the treatment of molar pregnancy? The treatment of molar is, please don't say methotrexate. The treatment of molar is suction and evacuation. Okay? Now, coming to the complicated pregnancies, we'll see all the antepartum hemorrhage and medical complications and everything. What is this? This kind of pathology happen in which medical complication? Please answer. This kind of baby can be seen in which complication? Now, this is an easy one. This is seen in which medical disorder in mother? Anybody? Yes? What is this problem? This is sacral agenesis or syringomyelia. It is seen in what complication? When the mother is diabetic. It is seen in diabetic mothers. When the sacral and the lumbar vertebra does not form, resulting in sacral agenesis. Okay? What is this? What does this graph indicate? It indicates 6x6x6 program for preventing which pathology? Which pathology? This program has been launched to prevent which pathology? Anemia. Okay, it has been presented to prevent anemia in pregnancy. It is the Anemia Mukt Bharat program, which has given 6 beneficiaries, 6 interventions and 6 institutional mechanisms to prevent anemia. What are 6 interventions that are advised in this program? Iron folic acid supplement. Okay, iron folic acid supplement has to be taken in by every woman starting from 14 weeks. Okay, starting from 14 weeks. And what is the dose of iron folic acid? Iron is 60 milligram elemental iron and folic acid here is 500 mcg. Okay, Second intervention is deworming. Every woman has to be dewormed in second trimester using what? Using albendazole. You have to give albendazole to every pregnant woman, 400 milligram in second trimester. So these are the 6 interventions that are advised. Intensified year-round change means we have to bring certain year-round change in our behavior as a practitioner to so that anemia can reduce. One example is delayed cord clamping. Delayed cord clamping is a behavior through which we can reduce the anemia. Okay? Testing anemia using digital methods like hemoglobinometers. Now we don't have to take the samples. You use digital methods through which through just a prick you can test the anemia. Food fortification, adding iron to products like your daily atta. You can add to your daily flour. That is food fortification. Addressing non-nutritional causes like malaria and fluorosis. So these are 6 interventions. What are these? Iron folic acid supplement. Please speak up with me. Iron folic acid supplement, deworming, year-round behavior change, food fortification, digital hemoglobinometer has to be used. What else? Addressing the non-nutritional causes. What else was there? Deworming. Okay, these are the 6 changes. Done? So this was about diabetes and anemia. Now coming to next, antepartum hemorrhage. What is this? This is a case of placenta previa. When the placenta is in lower segment. So we have 4 grades according to Brown's classification. Can you see placenta in the lower segment? Stage 1, low-lying placenta previa. The placenta is, can you see clearly placenta is reaching the os, not covering it, reaching the os. So it is marginal. Okay? Can you see it has covered the os but not completely? It is partial placenta previa. And last one is complete. Which one is dangerous placenta previa? 2B is called as dangerous placenta previa. Okay? In fact, 2B and below, all of them are called as dangerous placenta previa. What is this? Placenta is not low-lying, but can you see it has detached from its natural place? It is detached, so it is abruption. Normally situated placenta, that is the specialty. It is a normally situated placenta that is separated due to certain reason. It can be concealed when all the blood is getting collected. It can be revealed. Okay? Concealed and revealed. Abruption is the most common cause of DIC. Presentation of placenta previa and abruption are totally different. Okay? Abruption may patient will have bleeding plus pain, plus the uterus is always tense, plus the uterus is tender, and there is a woody feeling. Itna tight ho jata hai, it is a woody feeling. Whereas placenta previa may, along with bleeding, there is no pain. Okay? The uterus is relaxed. Okay? There is no tenderness. Okay, so their presentation is completely different. Now, what is this? Now we have come to twins. We have done the antepartum hemorrhage. Now we have come to twins. So what is this sign? When I see it is in twins, the central septum. Correct. Good. Good. Now there is somebody has come who is constantly answering. I'm happy. I'm happy not because of myself, but I'm happy that yes, you are active enough to listen and to answer. More you are active, longer you can attend, no? See, when I see a septum, can you see the septum? Take a second, let me just zoom it. Why it is not getting zoomed? Yes. When I see the septum and the lower part of the septum, some tissue is entering into it. Can you see from the base? See, septum is thin in between, but from the base, it is a thick base. So when the base is thick, we call it twin peak sign or the lambda sign. Twin peak sign and lambda sign indicates dichorionicity. It is a dichorionic placenta. That is what is indicated by a twin peak sign. Now see this one. Now see this septum is again thin in center, but look at the base where the arrow is there. Can you see the base is also thin? Base is not thick, it is also thin. So it is inverted T sign. Inverted T sign is a sign of monochorionic placenta. It is seen in monochorionic placenta. It is very important to know the chorionicity. Why? Because monochorionics has more complications and there are more chances of intrauterine fetal death. Question: what is the best time to know the chorionicity? When I get a twin pregnancy, what is the best time I should know whether it is monochorionic or dichorionic? The best time is 11 to 14 weeks. This is the time when I am doing my aneuploidy scan. So this is the time when I can detect the chorionicity in the best way. Okay? Question 2. Which type of twin is most common? Among DCDA, monochorionic diamniotic, monochorionic monoamniotic, and conjoined twins. Which is the most common? Overall, the most common is dichorionic diamniotic. Overall, this is the most common. Okay? Because majority of the twins are actually dizygotic. ज़्यादातर twins are dizygotic, and dizygotic जो दो zygotes हैं, these are two brother sister kind of twins who are just coming in uterus together, but they are completely separate. So because dizygotic twins are most common, DCDA is most common. But if the question is asked in monochorionic twins, in monochorionic which type is most common? The most common in monochorionic is this one. Okay, so in monochorionic, separation of a zygote happens. So the time when the separation happens, maximum time is 4 to 8 days, and this twin is most common. Okay, in monochorionic. Now the question is asked on the delivery of twins. So when this type of question is asked, remember pehli cheez, the first twin, whenever we say that first twin is the one that is lying near to cervix. The one which is near the os, that is the first twin. This one is the first twin. So for delivery, I only look at the first twin. If the first twin is kyphlic, doesn't matter what the second twin is. If the first twin is kyphlic, the patient can be delivered vaginally. If the first twin is non-kyphlic, अब चाहे वो breach है या transverse है या whatever, if this first twin is non-kyphlic, like in this, correct, LSCS. ठीक है? Here breach is the lowermost, so I'll go up with LSCS always. ठीक है? But if it is kyphlic, चाहे वो second वाला फिर breach क्यों ना हो, कोई बात नहीं, I'll do vaginal delivery followed by internal podalic version. ठीक? Now we come to the infections. ठीक है? Now we have done with medical complications. We saw few pictures of anemia and diabetes, and we saw about twins. Now we come to the congenital infections in pregnancy. Most common position is vertex followed by vertex breach followed by breach vertex. ठीक है? Now let's come to congenital infections. This baby has constant blood tinged mucosal fluid coming through nose. Also there is maculopapular rash. Also the tibia is anteriorly curved like this sword. It is anteriorly curved like this sword. What is the diagnosis? What is the diagnosis when there is a constant blood stained fluid coming out, maculopapular rash, and the tibia is anteriorly curved? You might also be given an image where there is a perforation in the palate. So this image can be given, perforation in the palate. What is the congenital infection that has been transferred to the baby? What is this infection? Any guesses? Maculopapular rash with curved tibia and with perforated palate and lot of nasal discharge, blood stained. What is it? Array, very good, brilliant. It is syphilis. It is congenital syphilis. So this sword is a saber sword. इसको हम कहते हैं saber sword, from where the term saber shin has come. It has become curved like a saber sword. So इसे कहते हैं हम saber shin. Maculopapular rash and sniffles, constant mucus coming from the nose which is blood stained. So rhinitis, sniffles are there. That is congenital syphilis. Very good. ठीक है? What is this? Next image. What is this? I can see a small gap in the scalp. What is this? This one. What is this condition? What is this condition, बच्चों? ओके मैं नाम बता देती हूँ. इट इज़, अरे वेरी गुड, एप्लेजिया क्यूटिस सीन इन विच ड्रग एक्सपोजर? विच ड्रग विल कॉज एप्लेजिया क्यूटिस? वेरी गुड. Carbimazole, methimazole, both will cause aplasia cutis if given in first trimester. What is my drug of choice for hyperthyroidism then? If a patient gets hyperthyroidism, what drug will I be using in case of pregnancy? What will be my drug of choice then? If I give carbimazole, it will cause scalp defects. What will I use? What will be my drug of choice? Carbimazole and methimazole both cause aplasia cutis. What is my drug of choice in hyperthyroidism? Propyl thiouracil. Always in a hyperthyroid woman, pregnant woman, propyl thiouracil is the drug of choice till 16 weeks. उसके बाद you can choose, but till 16 weeks you use propyl thiouracil. Good. ठीक है? So अभी teratology और कलेक्ट करेंगे हम लोग. We'll do more teratology, या फिर let me do more of teratology questions. Labor has come in between. Yes. Okay, what is this? I've mentioned the features also. Small eyes, small philtrum, pinched nose, everything is small. Thin upper lip. What is this? What is this, baby? Everything is growing less. Small eyes, small philtrum, everything has not grown properly. What is this condition? What was woman taking that she developed this kind of baby? What is this, बच्चों? Correct. Fetal alcohol syndrome. Perfect. Remember, fetal alcohol syndrome is a dose-dependent malformation. If she is taking less alcohol, only facial features will develop. If she is taking more alcohol, neural defects will start happening. If furthermore, the baby will be completely lump. ठीक है, completely lumpy. So it is a spectrum. ठीक है, so it is a fetal alcohol syndrome showing these facial features. Very easy. ठीक है, what is this? Phocomelia. Now it is not seen due to diethyl salbisterol. नहीं, D है. What is this? This kind of skull. This baby. मैं नाम ही भूल गई थी. I just forgot the name of the drug causing phocomelia. Thalidomide. Just slipped out of my mind. Yes. What is this one? This. Can you see the skull is different? The skull is not round. It is little different. What is it? Here. The skull is at very little different. It's not circular. Anybody? What is it? Looking like a leaf. एक leaf बनाते थे आप लोग in drawing like this. Clover leaf skull. It is clover leaf skull. The skull is like clover leaf. ऐसे and ऐसे. It's a clover leaf skull. Seen in case of methotrexate. In case of methotrexate exposure, the clover leaf skull is seen. ठीक है? What is this? Nasal hypoplasia. The nose has not been made. If you will see the joints also have calcifications. So what is this condition where there is nasal hypoplasia? Due to what embryopathy? Which drug? Correct. Yes, correct. But tell me, what is this? Nasal hypoplasia has happened because of which drug? Correct. Warfarin. It is warfarin embryopathy leading to chondrodysplasia punctata, where there is small multiple calcifications that happen in joints, and also the nasal hypoplasia happen because of warfarin. That is why, again, if a woman on warfarin becomes pregnant, because of this we switch her to low molecular weight heparin. Till first trimester we switch her. Once the first trimester is over, we again start with warfarin till 37 weeks. Okay, so a patient of mechanical valves, we always stop warfarin and start low molecular weight heparin for the first trimester. Okay, now this ultrasound, can you identify this baby? What is this baby? Frog like looking baby. What is it? What is this pathology? What this baby is looking like? A frog eye look. It's a case of anenchyphly. Anenchyphly, where the skull has not formed. Can you see the baby's skull has not formed and only the forehead and the eyes are visible? So it's a case of anenchyphly. Okay? So this was about teratology. Now we start with maximum image based questions, and that is labor. Okay? So labor has maximum images. Okay? Be very focused. More you will be focused, then we'll do it fast. Okay? We have to study other subjects also. I know you are very packed. So let's just finish this. Types of pelvis. The first pelvis, can you see a beautiful round inlet? Beautiful round inlet is gynecoid pelvis. Okay? When you see this pelvis, can you see this pelvis whose anteroposterior diameter is longer? AP diameter is longer, transverse is smaller. It is anthropoid. Can you see this? The transverse diameter is longer, but there is anterior beaking. Posteriorly also the space is extremely less. Can you see the posterior segment is smaller? Anteriorly there is beaking, and posteriorly also segment is very small. This is android pelvis. Correct. Very good. Very good. Android pelvis. And can you see this pelvis, a flat pelvis? It is a platyploid pelvis. Now important points. Which is the most common pelvis? Gynecoid. Which is the pelvis which is promoting the direct occipito-posterior position, or I can say face to pubes delivery. Remember, face to pubes delivery matlab in occiput posterior. See, if I am the baby, okay, and this is symphysis pubis, and the presentation is kyphlic, but my occiput is posterior. When I will deliver, when the baby will deliver, what the first part will come? First will be face. Occiput is posterior, the forehead is anterior. When it will deliver, face will come just below the pubic symphysis. इसे कहते हैं face to pubes delivery. They happen in case of anthropoid pelvis. Do not confuse it with face presentation. Face presentation is a completely extended head. Completely extended head where the face is over the cervix. When you do PV, you feel facial parts. Face to pubes delivery is not face presentation, it is kyphlic presentation, but the occiput is posterior. So face presentation is different. If the question is asked which pelvis promote face presentation, it is platypoid. But face to pubes delivery is anthropoid. Okay? You don't have to get confused. Dusra, the pelvis where deep transverse arrest happen. The head has entered into the pelvis, stuck at ischial spine and transverse diameter. There is no space to rotate. There is no space to rotate. It has stuck in the cavity. That is android pelvis. Android pelvis is the one where the baby enters fine but stuck in the cavity in deep transverse arrest. Okay? What is this? In gynecoid pelvis, I am trying to measure some diameter. What diameter I am trying to measure? What am I trying to measure? Yes. In deep transverse arrest, since the baby is at, the fetal head is at ischial spine, that is characteristic. It is at ischial spine, not below that. You can't apply instruments. Instrument has to be applied only when head is below ischial spine. So you can't apply instrument, and that is why the treatment of deep transverse arrest is cesarean. ठीक है? Tell me, what is the diameter I am measuring here? Correct, diagonal conjugate. Diagonal conjugate is a diameter which I can measure clinically. I can insert my hand from lower border of pubic symphysis till sacral promontory. But what I want to know is in the inlet, my baby is not entering the inlet. I do not measure diagonal conjugate in everyone. When the baby is not entering the inlet, I want to know कि भाई inlet is sufficient or not. I want to measure the diameter of inlet, which is from superior border of pubic symphysis to sacral promontory. I can't measure it. So I measure diagonal conjugate. When I subtract 1.5 to 2 centimeter, what I get is obstetrical conjugate. ठीक है? What I get is obstetrical conjugate. So this is the diagonal conjugate which is clinically measurable, and then I subtract this number and I get obstetrical conjugate. Done only in case when the fetal head is not entering the pelvis. What is this diameter which I am measuring here? Here. What is this diameter I am measuring using my hand on the outer surface? Beta, you are confused in what? So this one is diagonal conjugate is from lower border of pubic symphysis. आपने अपना हाथ डाला है ना? So pubic symphysis, this is pubic symphysis. When you insert your hand, this is pubic symphysis. You have inserted your hand below pubic symphysis till sacral promontory. You bring your hand out and you measure up till what level it was. So you are measuring from lower border of pubic symphysis to sacral promontory. Obstetrical conjugate is from upper border of pubic symphysis. You can't measure it clinically. So that is why you subtract 1.5 from it and you get obstetrical conjugate. If obstetrical conjugate is lesser, it means the head will not enter, right? Correct. It is intertuberous diameter between the ischial tuberosities. So if I want to measure the outlet, this is intertuberous diameter. Pelvic planes. Very important. Pelvic spaces and planes. See, imagine pelvic cavity is like a house. It's like a house. It has a door, which is a plane. Plane matlab two-dimensional structure. So door is the inlet. This is a two-dimensional structure running from superior border of pubic symphysis to sacral promontory. It is inlet. Okay? So this house has a very nice door from upper border of pubic symphysis till sacral promontory. Then there is a wall in between, and that's a small wall. That's a small wall. Okay? And that wall is from posterior border of pubic symphysis till S4, S5. So this plane is inlet, and this wall को हम कहते हैं, it's a small wall. It is called as plane of least pelvic dimension. Least pelvic dimension. ठीक है? It is running from posterior border here, from posterior border of pubic symphysis till S4, S5, and it is passing through the ischial spine. It is passing through the ischial spine. So it's a small diameter. We call it plane of least pelvic dimension. The other side of the door of this house is the outlet, and the outlet is running from lower border of pubic symphysis till the tip of coccyx, and it is anatomical outlet. So these are the three doors. This is a wall. In between here is the cavity. This room, a huge room, is cavity. This another room is obstetrical outlet. This another room is obstetrical outlet. Now if I want to tell how huge the room is, I need another plane. The purpose of this plane is to tell how big the cavity is. That is the only purpose. So there is a plane running inside the cavity to tell you how huge this room is. इसको हम कहते हैं plane of greatest pelvic dimension. Plane of greatest pelvic dimension is running in this room between inlet and plane of least pelvic dimension. This cavity has a plane of greatest pelvic dimension. It is running from again posterior border of pubic symphysis till S2, S3. It was till S4, S5. Okay? This area which is obstetrical outlet, this also has a plane. This plane is running from lower border of pubic symphysis. Outlet तो lower border से आता है ना, यहाँ से lower border of pubic symphysis till sacrum, till tip of sacrum. This is the plane of obstetrical outlet. anatomical outlet तो बिल्कुल outer door है, which is lying till the coccyx. So this diameter from here to tip of coccyx is your anatomical outlet, and in this small room, this is obstetrical outlet. Plane of obstetrical outlet is from tip of sacrum till lower border. So that is how this room is described. Inlet, plane of least pelvic dimension, anatomical outlet. In between these two, plane of greatest pelvic dimension and plane of obstetrical outlet. Simple. So by seeing these, can we define? This is inlet, obviously. This one from S2, S3 is the plane of greatest pelvic dimension. This one, S4, S5, plane of least pelvic dimension. This one from lower border till tip of coccyx, anatomical outlet. Okay? Got it? Now, certain grips. What is this grip? This is our first grip. This is the fundal grip. Our first fundal grip. ठीक है, फंडल ग्रिप का पर्पस क्या है? इट इज़ टेलिंग यू टू थिंग्स, द लाई, हाउ इट इज़ लाइंग, एंड द प्रेजेंटेशन, वेदर द हेड इज डाउन और द ब्रीच इज डाउन, दैट इज टोल्ड टू यू बाय फंडल ग्रिप. What is this? From fundus my hand shifts a little lower. What is it? Umbilical grip. It is umbilical grip. And by umbilical grip, what I am trying to know, where the back is. So what? Back kahin pe bhi ho. Why I am so interested in knowing where the back is, where are the limbs. Wherever is the back, where is my back, there is my occiput. है ना? So I will know the position, whether it is right, whether it is left, पीछे की तरफ है या और it is anterior. I will know the fetal head position. That is the purpose of umbilical grip. To see where the occiput is. To tell the fetal position. Okay? Third grip is the polyp grip, where I am trying to hold whatever is there in the lower segment. In polyp grip, I am confirming my fundal grip findings again. I am trying to know what is the lie. See, if the lie is transverse, the polyp grip will be empty. There will be nothing in it. So I will know the lie, and I will also know the presentation. Whether the head is down or the breech is down. Next. This is when I turn towards the pelvis of the mother. Up till now I am facing the face of the mother. Now I have turned to the pelvis of the mother. What is it? It is a pelvic grip. By pelvic grip, I want to know how much it has descended. I want to know the descent of the fetal head. Also, the attitude. What is attitude? The relation of the fetal parts with each other. Generally, attitude is in flexion. All the fetal parts are flexed with each other. It can be extended. So when I do the polyp grip, if the head is flexed, I can feel occiput and sinciput. If it is extended, I can feel more of sinciput. So I will know the attitude, and I will know how much it has descended. Okay? So these are the 4 abdominal Leopold grips. Done. Now can you tell me what is the position of this fetal head in pelvis? Who can tell me? What is the position of this fetal head? What is it? Options, I can give you the options. It is left occipito-transverse, right occipito-transverse, left occipito-posterior, right occipito-posterior. What is it? Sorry, not it's not anterior. The option is not there. It is in transverse, isn't it? But anyways, you are right. It is left occipito-transverse. Okay? So triangular area is occiput. Diamond is sinciput. So this is my occiput. First thing I am clear. It is always mirror image. The patient is lying in front of you. In lithotomy, she is in lithotomy. You are seeing vaginally. So she is in front of you. So mirror image. This is your left side. This is your right side. So this is left occipito-transverse. Okay? What is this one? Next one. What is this? Please tell me what is the next one. What is the next one, please, everyone? What is the next one? I'm waiting. Just see what is right side, what is left side, where is your occiput. Is your occiput is in transverse, or it is in posterior or anterior? Where is it? Please write down the short form. No, this is your left side, this is your right side. Where is the occiput? Occiput is here. Where is anterior and posterior segments? This is pubic symphysis, this is anterior. This is sacrum, this is posterior. So it is right side, right occiput, anterior. Like this one. Can you see occiput towards the sacrum? But on left side, left occipito-posterior. Okay? So that's how you will know. First see the occiput, see what is pelvis mein, where is anterior segment, where is posterior segment, and see the right and left. Done. Which is the least common presentation? See, the most common when the fetus is entering, the most common is this. Left occipito transfer is most common. The least common is direct occipito-posterior. Direct occipito-posterior is least common. Okay? Now, we are coming to the labor. So in labor, while you are delivering the baby, there are certain maneuvers that you have to do to prevent the perineal trauma. What is the first image? What is the first image? It is, so I think waiting for answers, I'm taking a lot of time. Let me just go through it. The first image is hands-on technique. Hands-on technique has been specially given by WHO to prevent perineal trauma. The purpose of hands-on technique is cover the perineum and flex the head. Whenever you flex the head, remember, whenever you flex the head, the smallest diameter enters. Flexion has the smallest diameter. So the purpose of hands-on technique is flexing the head. It is given by WHO to prevent the perineal trauma. This one is Ritgen's maneuver. Ritgen's maneuver is not given by WHO to prevent perineal trauma. Ritgen's maneuver may you put one hand under the chin and with other hand you pull the baby out. It is done when the mother is exhausted. When the mother is exhausted and you want rapid delivery, this is the time when Ritgen's maneuver is done. From chin, one on head, you pull it out. So this is Ritgen's maneuver, and the purpose is not for perineal protection. Hands on, where you flex the head and protect perineum, is for preventing perineal trauma. Okay? Okay? What is this scissor? I know all of you know this. This curved scissor is episiotomy scissor. The purpose of episiotomy scissor, why it is curved? So that I can give a mediolateral episiotomy. I don't want to give it medially. If I give it medially, what I can rupture? If it extends, it will rupture the anal sphincter. So I give mediolateral at an angle of 60 degrees. When is episiotomy given? Episiotomy is given just at the time of crowning. When the perineum is maximum stretched, I give it that time, at the time of crowning, at an angle of 60 degrees. Is episiotomy universal or is episiotomy restrictive? You tell me, is it universal or is it restrictive episiotomy that we follow? According to WHO, what type should be followed? Universal or restrictive? Tell me, universal or restrictive? What type of episiotomy should be given to the women? Universal मतलब सब में देना है, restrictive मतलब in few conditions. What practice should be followed? Episiotomy should always be restrictive. There is no universal episiotomy. You don't give it in everyone, you give it in specific conditions like breech, like tight perineum, like twins. Okay, it is always restrictive. What are the muscles cut in episiotomy? Good. So muscles cut in episiotomy are very, very frequently asked. So I explain it like this. So this is your perineum. This is the urethra, this is the vagina, and this is the anal canal. ठीक है. Now let's see the muscles which are cut in episiotomy. If someone, meanwhile, if you can write the names of the muscles which are cut, that'll be really good. Write down the muscles which will be cutting in episiotomy. This covering the vagina like a bulb, bulbocavernous. ठीक. Then we have certain sphincters, the anal sphincter and the urethral sphincter. Then we have a far away muscle here over the ischial tuberosity. It is ischio-cavernous. It is over the ischial tuberosity, ischio-cavernous. And then we have, here we have gluteal muscles. In between we have levator ani. Now tell me what are the muscles which I will be cutting in episiotomy. Still, have you mentioned some mnemonic or something? What I am cutting? Am I cutting bulbocavernous? Let me zoom it. Am I cutting green bulbocavernous? Yes. Am I cutting levator ani? Yes. Or one of them I forgot to mention here. Superficial and deep transverse perineae, which are separating the vagina and rectum. Transverse perineae. Now tell me the muscles which I will be cutting during the episiotomy. Am I cutting bulbocavernous? Yes. Am I cutting transverse perineae? Yes. Am I cutting the rectal sphincter? No. Am I cutting the ischio-cavernous? No. Am I cutting levator ani? Yes. So the muscles which are cut are bulbocavernous, transverse perineae and levator ani. I don't touch ischio-cavernous. I don't touch sphincters. Okay? These are the muscles that are cut in episiotomy. Now we come to third stage of labor. These are the two methods through which the placenta separates. Once the baby delivers, placenta separates on its own. So there are two methods. One is Schultz mechanism. See the image, Schultz, where the placenta, can you see, separates centrally. When this is uterus, this is placenta. It is connected here. But once the baby is delivered, it starts buckling onto its weight. वो अपने weight पे buckle करने लगती है, and it separates posteriorly. Blood is getting collected posteriorly. I can't see blood right now. So it slowly separates centrally, and once it is separated, then a gush of blood comes. So Schultz mechanism is a central separation where the gush comes once the placenta is separated. Another one is the Duncan's mechanism. In Duncan's, it is a peripheral. This is placenta, it is peripherally separating. It is peripherally separating, the blood is leaking out continuously. In Schultz mechanism, when the placenta delivers, the first face which I see is the fetal surface. The shiny surface where the cord is attached, that the part that comes first. In Duncan's, when there is peripheral separation like this, the first part that comes is maternal part. Okay, so here the fetal part is delivered first. Fetal face of the placenta. Fetal matlab chorionic plate. In Duncan's, it's a peripheral separation. Blood is continuously coming out, and the first part that comes out is the maternal part, which is more common. The more common mechanism through which placenta separates naturally is Schultz. This is Schultz, this is Duncan's. Schultz is more common. Okay? Now there are certain signs of placental separation. What are those signs? When the placenta separates, when the placenta separates, the fundal height rise. Placenta comes to lie below the fundus and the fundal heights rise. That is the first sign. Okay? Second sign is that there is a gush of blood. Third, if you have read, permanent cord lengthening. What is that permanent cord lengthening? That when in the image, when you are pushing the uterus above, using your hand you are pushing the uterus above, the placenta, the cord is not moving. Why the cord is not moving? Because it is no more a part of uterus, it is detached. So if you are pushing the uterus above, the cord is not moving. Cord is, can you see the arrow? It is still long. इसे कहते हैं permanent lengthening. Now the length doesn't change. ठीक है, इसको हम we also call it Schultz sign. When I push the uterus above, the cord doesn't change. It is permanent lengthening, a sign of placenta has separated from the uterus. ठीक है? Now the methods through which we will separate the placenta. ठीक है, remember third stage में what we do is always active management of third stage of labor. So there are two ways. What is this? What is this I'm doing? With one hand, I'm just pushing the uterus, controlling the uterus. With another hand, I'm not pulling it out. I have just maintained a traction. Traction maintain किया हुआ है बस. Nobody pulls. We are just maintaining a traction. इसे we call controlled cord traction. A step of active management of third stage of labor. Now see this image. Here I am not putting a traction on cord. I am pressing the fundus. When I am pressing the fundus, the placenta will separate and will slowly squeeze out. इसे कहते हैं Creed's method. So controlled cord traction is done in everyone, but certain times we can't put the traction on cord. It will lead to cord rupture, like in very preterm or in case of IUD babies. The cord is so thin I can't pull it. There we use the Creed's method. In Creed's method, we just squeeze the placenta out by pressing the fundus. Done in case of very preterm, no, it's not massage. It's a Creed's method. Massage is done once the placenta is delivered. Image में देखो, placenta is there. So you will not start massaging with placenta inside. Once the placenta is delivered, then you massage. No, ठीक है? It looks like massage, but how will you differentiate? Placenta is inside, so it is Creed's method. Okay. What is this method? So Creed's method is used in very preterm and IUDs babies. Another method here. Can you see the hand is inside uterus and it is trying to slice the placenta off? By this movement, it is trying to remove the placenta from uterine wall. It means it has not separated by itself. It is done in case of retained placentas. It is done in case of retained placentas where you try to manually remove it. And also it is done in case of the cord has got detached. You are pulling it, the cord has got detached now, so you insert hand and manually remove placenta. This one is manual removal. This one is Creed's method. This one is control cord traction. I have put images together deliberately so that you can understand the difference. Okay. Now we come to the abnormal fetal lion presentation. I think in 1 hour we will be able to finish. I think we should. In another hour. Abnormal fetal lion presentation. What is this? Breech. This one is frank breech, where the legs are extended. This one is complete breech. And this one, incomplete breech or footling breech. Which of these I can deliver vaginally? I can try delivering them vaginally. इसे हम कहते हैं trial of breech delivery. I can deliver frank breech or complete breech vaginally, but not footling breech. I can't deliver it vaginally. ठीक है? Breech delivery से related, there are so many maneuvers that you have to remember. Remember, breech delivery को we call assisted breech delivery. है ना? Assisted breech. Why we call it assisted breech? We need to assist at each step. ठीक है? We need to assist at each step. That is why we call it assisted breech delivery. So first, the baby. अब imagine करो, breech baby is delivering. Buttocks have come. If the legs are flexed like this, legs will come by itself. But if the legs are extended, it's a frank breech. The legs will not come out. Here the baby will need assistance. So assistance 1. Assistance 1 to deliver the extended leg. What is this? Groin traction. See the image, remember it. Groin traction done in frank breech. Another way of delivering the fetal legs. Pinard's maneuver. This is the leg. I pin the popliteal fossa, hold it, bring it out. It is Pinard's maneuver. So these are the two maneuvers done to deliver extended legs. Now legs have come out. Now baby is coming out slowly. If the hands are flexed like this, hands will follow. If the hands are extended, इसे हम कहते हैं nuchal arm. Hands are extended like this. Now hands के लिए भी there is assistance needed. So this was the first assistance. This has now come second assistance to deliver the extended hands. ठीक है? What is this one? You try to bring out the posterior shoulder. Posterior shoulder sweeping. You try to sweep out the posterior shoulder. This one, where you are rotating the baby. Can you see that one arm is extended posteriorly? So what do? you rotate it. You rotate it so that it comes, sorry, this anterior arm is extended. So you rotate it so that it goes posterior and at least one arm is delivered. इसे हम कहते हैं Lovset maneuver. Lovset maneuver में you hold the baby by pelvic girdle. Remember, by pelvic girdle you hold and you rotate to bring the extended arms. Pinards for extended legs. Now legs have come out, shoulders have come out. What is there inside? Head. So assistance 3 to deliver the head. What is this? You let the baby hang on your left hand, with right hand you flex. Remember, whenever you flex, small diameter has to come out. So it is 𝑭𝒂𝒂𝒉 maneuver. Can you see? You let the baby hang, you hold the feet and turn the baby over mother. Now you don't do this method. Why? It leads to extension injuries in neck. But yes, once it was a way to deliver the head. This is Burn Marshall. Burn Marshall. For delivering the head. For delivering the feet, what did you do to deliver the extended legs? You did groin traction and pinards. For hands, extended hands, you did 2. Sweeping the other shoulder and Lovset. For head, you do 𝒚 or Burn Marshall, or you use a forceps, which is curved shank, and it is called as Piper forceps. Piper forceps is used for delivering the extended after coming head in breech. So these are the 3 ways through which you can deliver the head. Okay. Remember, whenever the breech is delivered, you should always remember the back should always be anterior. Can you see? The back is always anterior, dorso-anterior. But sometimes the back turns posteriorly. Okay? In case the back turns posteriorly, that is when you do this maneuver. Just slip the name again. Hindi? See, in breech, you got all the images of breech, no? ठीक है, जब भी breech deliver करते हैं, the back should always be anterior. ठीक है? Sometimes the back turns posteriorly. So when the back turns posteriorly, we do this maneuver. Can someone tell me the name of this maneuver? Again, it has slipped out of my mind. What is the name of this maneuver when the dorso is posterior? To deliver a dorso posterior baby? Just give me a second. Not Burn Marshall, Betu. Modified Prague maneuver. What is Burn Marshall? This is Burn Marshall, where you let the baby hang and then you just curve it over the mother. That is Burn Marshall. To deliver a back posterior, what you use is a modified Prague maneuver. Okay? This is modified Prague maneuver for a back being posterior. Okay? What is this lie? What is this lie? The baby is at 90 degrees to the uterus. So what is this? This is a transverse lie. Whenever the baby is in transverse lie, now question comes, baby is in transverse lie at 36 weeks. What will be your maneuver? Sorry, what will you do next? A patient comes to you at 36 weeks. What will you do in this case? She is not in labor. So whenever you see a transverse lie baby, what is your first step you do at 36 weeks? What will you do? Will you do the cesarean? Will you try to pull it out vaginally? Will you try to do internal podalic version? What will you do in a transverse lie patient? Correct. External Keflik version. Always, whenever there is breech, whenever there is transverse, we do external Keflik version at around 36 to 37. Obviously, we will not do it if there is a contraindication, but if there is no contraindication, first step is always external Keflik version. Tick. Now, what is this? See here. See the head, can you see head is not completely flexed, but head is not completely extended, it is in between. Can you see the part that is just above the os? Just above the os, this forehead part is there. It is brow presentation. Second image, just above the os, the face is there. It is face presentation. So question can be asked, in this image, what is the diameter, which is the presenting diameter? So first know that when the forehead is coming just above the cervix, it is brow presentation and the diameter is mento-vertical, which is a huge diameter of 14 centimeter. Can I deliver it vaginally? No. I always have to do cesarean. Can you see the face? In face presentation, the diameter is submento. This is submento, this is bregma. So face, what is the diameter? Submento-bregmatic. So submento-bregmatic is the diameter and it's a 9.5 diameter. So can I deliver a face presentation? Yes, but only when mentum, yani chin is anterior. Okay? Can you see here the chin is posterior? So mento anterior, vaginal delivery, mento posterior, cesarean. Brow, always cesarean. Transverse lie, external kyphlic version. In case it fail, then cesarean. Okay? Types of forceps. Can you see this small forceps? Small handle, small shank. So small forceps means to deliver the fetal head which is not very high above. If the fetal head is high above in cavity, we can't use a small forceps. So this forceps is used to deliver the baby which is at outlet. We don't need so much length. So outlet forceps are small forceps. Okay? One outlet forceps is Wrigley's. Wrigley's is the most famous outlet forceps. इसका एक Indian version भी आता है दास. ठीक है? Another forceps, long handle, long shank. It is a mid-cavity forceps for delivering the head which is in the cavity. Simpson. So Simpson is a mid-cavity forceps. Can you see this forceps? Can anybody tell me the name of this forceps? Where? If you see the other forceps, when they are locked, the handle are opposed, but the shanks are apart. Can you see that this is shank? Shanks are apart. है ना? In this forceps, it is reversed. On closing, on locking, the handles are apart, but the shanks are closed. What is this forceps? Who will tell me the name of this forceps? Who will tell me the name of this forceps? When it is locked, the presentation is completely different from the routine forceps. What is this? Different type of forceps. Oh, good. By Dr. Kedarnath Das. Tell me the name of this forceps, bachche. Correct. It is keel end forceps used for rotational deliveries. Rotational matlab occiput posterior hai, transverse hai, but below is still spine. Then you use keel end forceps. Okay. What is this forceps? With the shank V's curved. We have just done it. Yes, a Piper forceps. For a breech delivery, Piper forceps. So see all the forceps so that you remember which one is what. Okay. Vacuums, types of vacuums. So another instrumental deliveries is vacuum. Can you, so there are three types of vacuum that come. One is celastic vacuum. Makeup of celastic cups. This one is metallic cup vacuums. Good. Metallic cups. And can you see this one? This one is 𝒌𝒉 cup. Celastic and metallic need electric suction. To this pipe you attach to a suction machine. You need electricity and they are very powerful. 𝒌𝒉 cup was developed for the peripheral areas. Where, can you see there is no suction pump, there is no place to connect suction pump. Suction is created manually. Can you see this machine? We hold it and manually we create the suction. Problem is that it is not very strong. The power that it is produced is not very strong. Dusra, it is not reusable. Once it is used, it has to be discarded. That is why 𝒌𝒉 cup is not very well used. But you should know the image. This is 𝒌𝒉 cup. This is metallic vacuum cup and this is celastic cup. Okay? Now where is vacuum cup applied? Vacuum cup has also been, ये नहीं कि scalp पे कहीं भी लगा देंगे, no. You have to apply it on a particular area जिसे हम कहते हैं flexion point. So you apply it onto the flexion point so that when you are applying it on the flexion point, flexion can be achieved. You are also pulling and also the head is flexed. Where does the flexion point lie? Flexion point lies at the center of the vacuum cup should be 3 cm ahead of posterior fontanelle. So you call it that the vacuum is applied 3 cm ahead from posterior fontanelle, beta. 3 cm from posterior fontanelle. The center of the cup is 3 cm ahead of posterior fontanelle. So when it is applied this way, the rim, the posterior rim is on the posterior fontanelle. So there are two ways of describing flexion point. The center of my cup ka center should be 3 cm from posterior fontanelle, or the posterior rim is on posterior fontanelle. These are the two ways of describing the flexion point. Okay. So this we have finished the instruments. Now we will do the obstetric emergencies. Once we have done the obstetric emergencies, then we have to do the antenatal surveillance. Finish. Then we'll go for gynecology. Another half an hour may we'll finish gynecology. I'll just get some water for myself if that's okay. I'm just coming. Yes, I'm back. Obstetrical emergencies, just see the image. What is this maneuver? This is suprapubic pressure and shoulder dystocia. Question, this maneuver is done in which pathology? It is done in shoulder dystocias. Okay, McRoberts and suprapubic pressure. But before giving this maneuver, also remember, जैसे shoulder dystocia happen, the first thing is axial traction. Always try to apply an axial traction, means in the axis of the baby. Lateral traction like this is never applied, you will injure the brachial plexus. The first step after shoulder dystocia is axial traction. If it doesn't work, then you go for McRoberts like this one. Okay. What is this? So this is Gaskin maneuver. Again done in case of shoulder dystocia. Right? Gaskin maneuver. No, partogram not discussed yet. Partogram I'll discuss in last. Okay, I have not discussed partogram yet. This is Gaskin maneuver, all fours position. Now when the maternal maneuvers have finished, when the maternal maneuvers have exhausted, we go to internal maneuvers. I insert my hand inside and I start doing maneuvers. First internal maneuver is sweeping the posterior shoulder. Anterior is stuck, so bring out posterior shoulder. It will reduce the diameter. If that doesn't work, you do the rotational maneuvers. Rotational maneuvers are two. So what are rotational maneuver two? One is can you see in this image when the pressure is applied on the dorsal aspect. Dorsal aspect where pressure is applied so that it flexes like this. First it will rotate and this diameter is reduced. So on dorsal aspect when the pressure is applied, it is called as Rubens maneuver. Rubens 2 maneuver. Another one is Wood's corkscrew. Wood's corkscrew means the pressure is applied on the ventral aspect. So Wood's corkscrew is done along with Rubens. Ab Rubens kar rahe ho, the baby is not coming out. So along with Rubens, insert your another hand and do Wood's corkscrew. Try to rotate. One on dorsal aspect, one hand here. Try to rotate the baby. So by rotating the baby from anterior posterior diameter, you rotate it to oblique diameter, which is larger. So Wood's corkscrew and Rubens are done together to rotate, bring the baby in oblique diameter. Okay. What is this? Cord occult? No, this is cord presentation. When the cord has not crossed the head, it is lying just beside the head. It is cord presentation. This is occult cord prolapse. Cord is about to prolapse. It is not prolapsed because of the membranes. So the cord has come beyond the head. Cord has come beyond the head but not into vagina because of membranes. इसे कहते हैं हम cord Gaskin maneuver in, yes, Gaskin maneuver basically to relieve the cord compression, Gaskin position is taken. That is the same one. This is cord presentation. But Gaskin से better positions which can be taken in cord prolapse are Trendelenburg position, knee chest position, all four position, that is Gaskin. So that is the third option. But yes, that is done. Cord presentation, this is occult cord prolapse. I'm just showing the image in case it comes. What is the diagnosis? Occult cord prolapse. What is the management of this condition? Always LSCS. This is cord prolapse. This one is cord prolapse. So once the cord prolapse has happened, your own aim, whole soul aim is deliver the baby. Deliver the baby as soon as possible. Meanwhile, when you are delivering the baby, meanwhile when you are shifting the baby, you try to relieve the cord compression. Cord is compressed between this head of the baby and pelvis. So you try to relieve that compression. You never touch the cord. The cord loops which are out, you never touch them. You try to just relieve compression by two methods. One is by pushing the fetal head above, or Vago's method. If you get this image, can you see this image? The cord loops are coming out. Can you see the loops coming out? Now the bladder is being filled. Bladder is filled with almost 400 to 5 ml of saline, and that filled bladder will push the head above. Once the head is pushed above, the pressure on the cord will be relieved for some time while you are transferring the patient to the cesarean. So it is temporary method to relieve compression. So can you see the image? Cord is out, bladder is being filled. So it is Vago's method to relieve cord compression. So whenever you get an image based question, see it as a whole. Okay? See it as, don't just see the, oh, something saline is being filled. Don't try to make it like, oh, Sullivan method hoga, saline is being pushed. Okay? Just see where the saline is being pushed, what pathology is happening. So see the image completely, whole solely. What is this? Another uterine, another obstetrical emergency. A patient has just delivered and she has gone into shock. Blood loss is not much, but shock has happened. When you put your hand on abdomen, uterus is not palpable. You see a shaggy mass coming. What is it? It is uterine inversion. It is uterine inversion. Uterine inversion abdominally, can you see? It looks like this. The whole uterus has gone inside. So this is uterine inversion. Vaginally and abdominally. Okay? For uterine inversion, what do? You stop the oxytocin. You call help. You start fluid. You do not remove the placenta. I am just revising the steps of uterine inversion. You do not remove placenta. You reposit the uterus then and there in the labor room itself. Remember, you don't shift to the OT immediately. Immediately you revert using two methods. One is this one. Can you see an inverted uterus? Hold it. I'm holding it in my hand and I'm pushing it back like this. Making a fist of my hand, right. I'm pushing it back. What is this maneuver? What is this maneuver I'm doing for reverting the uterine inversion? What is this? Right. It is Johnson maneuver. Correct. If I am using saline for the same method, if it is just a fundal cupping, mild inversion has happened and I am using saline to re-invert it, then it is O'Sullivan method. So that was Johnson method and this is O'Sullivan method. Okay. Now we come to postpartum hemorrhage. When the postpartum hemorrhage happen, what do? We start with uterotonics first, among which our drug of choice is oxytocin, followed by carboplast, followed by methogen. If the uterotonics don't work, I go to mechanical methods, which is this. This is what? Uterine balloon tamponade. Using either Foley's catheter or by using Bakri balloon, Sengs taken by Blackymore, all these I do balloon tamponade. I have to fill this uterus, with this Foley catheter with around 400 to 500 ml of saline. This much saline it is filled with so that it inflates and blocks the bleeding vessel. It is uterine balloon tamponade with 80% success rate. Once it is successful, I keep it there for 24 hours. Remember, uterine balloon tamponade is not removed for 24 hours. Once the bleeding has stopped, I keep it there, then I remove it after 24 hours. This is what procedure? This is a bimanual compression. This is bimanual compression. So when a patient has undergone PPH, I tried balloon tamponade, it is not working, I decide for surgery. So while I'm shifting her to maybe a better hospital, while I'm shifting her to the OT, I have to now, so much blood is lost, I have to save the patient. So I use certain temporizing measures. Temporizing measures are not curative measures. Only temporarily I'm trying to stop the bleed. I'm trying कि जितना भी blood है, whatever blood is remaining, it should remain towards the vital area, the heart and brain. So temporizing measures are being used only when you are shifting the patient. So like bimanual compression, aortic compression is done just near the umbilicus towards the left side. So aortic compression, bimanual compression, aortic compression, and using this non-pneumatic anti-shock garment. Non-pneumatic anti-shock garment. The purpose is I'm not treating PPH, no, I'm buying time. I'm trying to keep the blood, whatever is remaining, towards the visceral areas. And then I'm shifting the patient for surgery. Bimanual compression, aortic compression, non-pneumatic anti-shock garment. See all the images. Okay. What is this? See first image. What this surgeon has done. What procedure this surgeon has done. What pathology might have happened in this patient. Why the surgeon has applied this. Who will tell me? What is it? Perfect. Beautiful. It's B-Lynch. Can you see how the uterus is tied so tightly? It's a surgical management for people. If the patient is bleeding and not managed by uterotonics or by balloon tamponade, you use surgical methods where you give B-Lynch suture. This is B-Lynch, and sometimes you don't give B-Lynch, you just apply 4 square sutures. This is CHO sutures. Okay? Okay? One other method you do is selective vessel ligation. Now question is asked, which vessels you ligate in selective vessel ligation? Remember, the vessel which is bleeding, you will ligate obviously uterine artery. You will ligate the ovarian artery. If they don't work, you ligate the main origin of them. Uterine artery is branch of which artery? Who will tell me? Uterine artery arises from which artery? What is the parent artery of uterine artery? So I will try ligate uterine artery followed by ovarian. If it doesn't work, I'll tie the parent artery, which is what? Uterine artery is coming from where? Which division? Anterior division of internal iliac. So I will ligate 3 arteries: uterine, ovarian, anterior division of internal iliac. Anterior division internal iliac is ligated 5 cm away from this junction. See, 5 cm away from this junction means when the posterior division is given. Posterior is given, then only you ligate only the anterior division of internal iliac. Okay? What is this procedure being done? Who will tell me? Though the picture is of fibroid, but we also do this procedure when through, can you see, through femoral artery, I am inserting a catheter going into external iliac, then internal iliac, and then uterine. What is this procedure? What is this procedure being done? Everyone? So though it is not a surgery, one thing I should tell you, it's not a surgical procedure, it is a non-surgical procedure. Through a small cut in inguinal area, I will enter the catheter into the femoral artery, then the external iliac, internal iliac and uterine artery. What is this procedure being done? Just write the short form, don't write full forms at all. Uterine artery embolization. Using radiological methods, using radiology, I will insert the catheter under radiological guidance, inject some embolizing particles and will block the bleeding vessels. This is the diagram of uterine artery embolization. Okay? Remember this image. Now we come to antenatal fetal surveillance. Once this is finished, we will go to the gynecology. Okay? Uterine artery antenatal fetal surveillance means antenatally I want to know whether the baby is doing fine or not. So I check for fetal heart. So when I am checking a fetal heart, what do I have to see? I have to see first the fetal heart rate. So the fetal heart rate should be between 110 to 160 beats per minute. Okay? Variability. See, fetal heart rate is not like this. It is like this. Right? It is like this. Okay? So variability means there is a gap between peaks and the trough. So variability is 5 to 25 beats per minute. है ना? Then accelerations. In a normal fetal heart rate, there should be at least 2 accelerations in 20 minutes and there should be no deceleration. This is NST, non-stress test, where I am taking only the fetal heart. When I am taking only the fetal heart, seeing the acceleration, variability and no deceleration, that is NST. CTG होता है cardiotocography. CTG is done during labor. When I am seeing the change of fetal heart with uterine contractions, that is CTG. NST is antenatally कोई contraction नहीं है. She is not in labor. I am only checking how good the fetal heart is by seeing the acceleration, by seeing the variability, by seeing the rate. जैसे ही contraction डाल दोगे, as you enter the uterine contractions and see the change in the heart with contraction, that is CTG. Now conditions. Can you see this heart? It is oscillating at a constant rate, The variability is not changing. It is sinusoidal pattern seen in case of fetal anemia. Okay? Now this is CTG, where I see how the uterus is contracting and how my heart is responding to it. Cardio, fetal heart, toco, uterine contraction, graphy. Cardiotocography. NST is non-stress test. The baby is not in stress. Simple. So, can you see this one? The uterus is contracting and with each contraction, the heart is decelerating. And the peaks are matching. They are together rising, together starting, together peaking, together going. So peak is matching. This is early deceleration. Early deceleration happen only when in labor the head is compressed on pelvis. Each time head is trying to go down, it is being compressed on the pelvis. That is why the heart is decelerating. Is it clinically significant? No. It is just a sign that head is trying to enter into pelvis. It does not indicate any kind of problem or hypoxia in the baby. See the second one. Contraction is starting, then the deceleration happen. At the peak of contraction, the deceleration happen. At the C, can you see at the peak of contraction, deceleration start. Their peaks are not matching. Late deceleration. Late deceleration indicate utero-placental insufficiency. So do we have to take some steps? Yes. If there are late decelerations, give the women oxygen, stop oxytocin, put her in left lateral. If late deceleration continue, either deliver or do a scalp pH, fetal scalp pH. So late deceleration is clinically significant. Third type of deceleration, which has nothing to do with contraction. See, here it is coming here. यहाँ पे contraction के साथ आ गया. It has no connection with contraction. It is variable deceleration. ठीक है, it is variable deceleration. Variable deceleration happen because of Cord compression. Give me a second. Let me put my phone to the charger. Oops. Yeah. Good. Okay, so variable deceleration is because of cord compression, and here also if the variable deceleration does not improve by changing in left lateral and oxygen, you have to deliver. Okay, so you will deliver if the variable deceleration does not go. So variable deceleration and late deceleration has to be taken seriously. Okay, so this was all about labor and surveillance. The postpartum, basically few images are there in postpartum. What is this? What is the hormone responsible for this action? This is an FMG question, but I really like the question. What is the hormone responsible for this action? Baby is sucking, something going in brain, coming down. What is it? Which hormone is responsible for this action? Oxytocin. Correct. So when the baby is sucking, what is happening? The signal is going, oxytocin is releasing, and whatever blood milk is there in the alveoli, that is pushed out. Muscles are contracting because of oxytocin, and that that milk is pushed out of the alveoli into the lactiferous duct. इसे कहते हैं milk let down. Milk is collected in the alveoli, that has to go out, and that happened because of oxytocin with each act of sucking. So this is oxytocin. Graph of early and late deceleration. This was early deceleration. Early, can you see the peak of deceleration is matching the peak of uterine contraction? They start together, they end together. So it is a sign that the head is entering in pelvis. When it is entering the pelvis, it is getting compressed, and that is why a vagal response is happening. And as soon as the contraction goes, the head is above, the deceleration goes. That is early deceleration, not very significant clinically. Late, can you see in this one? I should remove the, let me just erase this one. The peaks are not matching. When you see the peak of contraction and the peak of deceleration, can you see they are not matching at all? They are not matching. The peak of deceleration is coming little after. It is starting a little after. It is starting when the contraction is peaking. They are not starting together. It is following the contraction. That is late deceleration, and it is a sign of uteroplacental insufficiency. That is a sign of chronic hypoxia in the baby. There is chronic hypoxia, somehow it is maintaining, but as contraction comes, heart falls down. So it's a sign of early delivery. You have to immediately deliver. This is variable. Okay. Now, certain breast complications in postpartum. So this, can you see a red inflamed breast? This red inflamed breast, which is mostly unilateral, is mastitis. How can you differentiate it from breast engorgement? Breast engorgement means breast is filled with milk. It is painful. It is never red and inflamed. Mastitis means it is unilateral. Breast engorgement is bilateral. And it is red inflamed, and patient always has fever because it is an infection. So here you have to treat with the antibiotic. Can you see here, when the mastitis is not treated, then it turns into a pus-filled cavity. It is a breast abscess. Now breast abscess has formed. Now the treatment is not only antibiotics but incision and drainage, followed by antibiotics. ठीक है? ये हमने डिस्कस कर लिया. We have discussed this. So we have finished obstetrics. Once I finish gynecology, then I will tell you how to read and how to plot a partogram. ठीक है? First let's finish the gynecology. Okay? Gynecology में not many images are there, as not as many as obstetrics, but let's see. What is this? Can you see this white ovarian tissue? Pelvis में only one thing is white, that is ovary. But can you see how streak like, line like it is there? Streak. Normal ovary is like this. White circular, it is streak ovaries. Streak ovaries seen in case of gonadal dysgenesis. If a question comes, patient of primary amenorrhea, this ultrasound, what will you say? What will you say her? What will you tell this patient when there is a streak gonads? Primary amenorrhea, streak gonads. What it is? Gonadal dysgenesis. Most common cause of gonadal dysgenesis. Just wait. Most common cause of gonadal dysgenesis, Turner syndrome. Most common cause of, यार अमन को बुला लो, रजत क्या करेगा उसमें, अमन को बुला लो. अच्छा अच्छा, अभी कोई पेशेंट नहीं है ना? ठीक 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 ओके, ठीक 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 है, नहीं वो कोई प्रॉब्लम नहीं, वो कोई प्रॉब्लम नहीं, वो चले जाओ, चलो ओके ओके. Most common cause of primary amenorrhea, Turner syndrome. Or I can say most common cause of primary amenorrhea, gonadal dysgenesis. Okay, it's just the same. What is this? Another cause of primary amenorrhea. It is a cryptomenorrhea. Can I see a bluish bulging membrane? Yes. So what is it? It is imperforate hymen. Okay. When I see a pink muscle-like membrane, see here membrane is just onto the opening. There is no vagina visible. Absolutely no vagina, just at the opening. But can you see here a pink non-bulging thick muscle? Small vagina is visible. Small area of vagina is still there. So that is transverse vaginal septum. Okay, it is transverse vaginal septum. So imperforate hymen and transverse vaginal septum. Okay, causing cryptomenorrhea. पता है इनको कैसे डिफ्रेंशिएट करते हैं? इट इज़ पिंक, इट इज़ ब्लूइश बल्जिंग, इट इज़ नॉन बल्जिंग पिंक. ठीक है. द क्वेश्चन हैज़ कम इन नीट दैट पेशेंट कम्स विथ क्रिप्टोमेनोरिया, साइक्लिकल पेन, एंड ऑन PR vaginal fullness is there. Vaginal fullness means whole vagina is filled with blood. But in transverse vaginal septum can happen anywhere in the vagina. It can be high, it can be low, anywhere. Generally it is high. So in high transverse vaginal septum, the vaginal fullness is not there. Why the vagina will be filled with blood? It is not. Also, imperforate hymen means since whole vagina is filled with blood, the urethra gets compressed. So there is urethral compression and bladder outlet obstruction हो जाता है. Because पूरी vagina is filled with blood in imperforate hymen and the urethra anteriorly is compressed. Here, no bladder outlet obstruction. Bladder outlet obstruction does not happen. So these are the two ways through which question can be presented. Patient with cryptomenorrhea, vaginal fullness and urethral obstruction present. Imperforate hymen. Okay? Now secondary amenorrhea. The most common cause of secondary amenorrhea, anovulation. Anovulation is the most common cause of secondary amenorrhea. What is the most common cause of anovulation? This is how ovary look like. Multiple small cysts surrounding the ovaries. Remember the rule of 10. 10 to 12 follicles less than 10 mm and the ovary is more than 10 cc. Okay, so multiple small follicles and ovarian volume has enlarged. That is PCOS. PCOS has lot of other symptoms. How do you diagnose? No, array? No, it is not OHSS. I'll just show you what is. I have shown you OHSS in case of molar. Remember जो molar में बनती हैं theca lutein cysts, they are also hyperstimulated ovaries. So they are, how are they looking? See, अब तो मुझे दिखाना पड़ेगा. This is PCOS, okay? Now let me show you OHSS. This is OHSS. They are not peripherally arranged. They are not small. They are large, filling the whole ovary. This is OHSS. ठीक है? This is PCOS. In PCOS, remember, it's a genetic condition. You can't correct PCOS, but you have to correct the symptom. If the patient has problem of hyperandrogenism, what is the treatment? You give oral contraceptive pills. If the problem is of menstrual irregularity, you give oral contraceptive pills. If the problem is infertility, you give ovulation induction drugs. One other procedure you do in infertility is this. In PCOS, you do ovarian drilling. Ovarian drilling is done so that laparoscopically it is done so that these small follicles can be ruptured. When they are ruptured, suddenly for 6 months the testosterone, the androgen level fall and women start ovulating. It is a transient effect that will happen, but it is very good. So ovarian drilling is done in PCOS for infertility. Another cause of secondary amenorrhea. What is this? When I have injected an HSG dye, I can see the gaps in the uterine cavity. It is Asherman syndrome. Okay? This is Asherman syndrome, causing secondary amenorrhea. Now coming to abnormal uterine bleeding, what is this? A bulky monoclonal tumor of the uterus, fibroid. This is fibroid. How does fibroid look on the ultrasound? It is located at a one place. Whole uterus is normal. Can you see? This is the uterus. This is the uterus. A small cavity. It is growing nearby posterior wall. So it is a non-uniform enlargement. Uterus is enlarged but non-uniformly. Only one segment is enlarged. Okay? This is what? Coming from cavity. This is polyp. So you have to remember the ultrasound. Pura uterus, can you see? The pura uterus is normal. Just one segment has got enlarged. This is fibroid. This small growth in the cavity is polyp. How polyp looks on ultrasound? Can you see like this? This one. A cavity is there, but cavity mein I can see a little growth. Now why it cannot be fibroid? Fibroid kyun ho sakta? It can be a submucosal fibroid. Polyp has a single feeding vessel. Only one vessel feed the polyp. Whereas in fibroid it is not so. Can you see the above image? There are multiple feeding vessels. So whenever a fibroid is there, submucosal, intramural, it has multiple vascular supply. Whereas polyp has a single vessel. That is how I differentiate between a polyp and a fibroid. Okay, otherwise they look same. Correct, perfect. Now this, that was an irregular uterine enlargement. Can I see the uterus has enlarged but very uniformly? The whole uterus has become as like a ball, like a globular uterus. And there are also multiple cysts. What is it? Can you see whole uterus is so enlarged like a ball? What is it? Adenomyosis. The whole uterus is uniformly enlarged. Adenomyosis is endometriotic tissue, endometriostic tissues. Some of the tissue from the endometrium has gone into the myometrium. And it has gone into the myometrium. That is why the whole uterus has got inflamed and enlarged. And the cyst which you are seeing on ultrasound, these cysts are nothing but those small endometrial tissues that are forming the cyst. If this endometrial tissue, instead of going into myometrium, goes outside, cavity ke bahar nikal gayi hai, it is endometriosis. See the image. There is so much inflammation produced in the peritoneal cavity because of these endometrial tissue being there. It results in frozen pelvis. Can you see the pelvis has got stuck? How badly it is stuck? A cyst form. When this endometriotic tissue reaches the ovary, it bleeds every month. And the cyst is filled with a chocolate color fluid. It enlarges. Can you see these powder burn areas? So this, all of them are a same pathology. This correct, endometriosis. This chocolate cyst looks like this. Ground glass appearance. ये जो black वाला है, see, this one is a simple cyst. But this ground glass, it is not completely black. It is ground glass appearance. इसे कहते हैं chocolate cyst. Chocolate cyst has a ground glass appearance. So all of these adhesions, powder burn areas, chocolate cyst is endometriosis. The diagnosis of endometriosis is via laparoscopy and confirming the lesions using histopathology. That is the diagnostic method of choice. The diagnostic method of choice for fibroid, for adenomyosis is MRI. The diagnostic method of choice. The diagnostic method of choice for fibroid is ultrasound. For polyp, hysteroscopy. These are the diagnostic method of choice. Okay. What is this? In abnormal uterine bleeding, no matter if a patient is beyond 40, then even if there is a fibroid or there is a pathology, still you take endometrial biopsy. You want to rule out hyperplasia in cancer. So anybody beyond 40 years or anybody with no relief on medicines, okay? Anybody with endometrial thickness more than 12 mm or anybody with high risk of endometrial cancer, you do biopsy using this. It is 𝑃𝒆𝒄. 𝒃𝒆𝒄 is a very thin plastic cannula where you take the endometrial sample in the OPD itself. So it's a very simple procedure. 𝒃𝒆. See the image. It's a small plastic cannula. Okay. Hymen. The question has been asked on this hymen. This is a normal hymen tissue. This is a normal hymen tissue. This is imperforate hymen. This is a micro hymen, very small opening. Cribriform hymen, septate hymen. So these are anatomical embryological disorders that can happen in hymen. Okay. Coming to HSG now. HSG has been extremely useful in diagnosing uterine anomalies. They are not diagnostic method of choice, but yes, very useful in diagnosing uterine anomalies. This is a normal HSG. Can you see a normal uterine cavity, thin tubes and spilling dye? This is normal HSG. When I am using two cannulas and I see two separate vaginas, cervix and uterus, it is uterus didelphys. Two cannula are used because patient has two vaginas, and when everything is two, it is uterus didelphys. Can you see one cannula is used and cervix also fused, but uterine cavities are two? It looks just like septate. Septate maybe there is one vagina, one cervix, but two cavities. Now it can be bicornuate or septate. When the horns look very far away, there is a theoretical definition. Horns ka angle is more than 120 degree. They are 4 centimeter apart. You can't measure distance here. है ना? That's a radiological dimension. So it is, I always teach my student, it's a perception. If you perceive the horns are far apart, if they look far apart to you, you are not going to measure the lesion, the angle. It is bicornuate. When the horns seems far apart, it is bicornuate. When it seems horns are trying to come close, they are not falling apart. In bicornuate, they are falling apart. In septum, they are trying to be close. It is uterine septum. They look very similar and difficult to differentiate. Okay? What is this? Can you see the tubes are thick? Can you see the normal one? So thin tubes, ribbon-like, and this is spillage. The dye has spilled into the cavity. It has showered into the cavity. Now can you see there is no spillage and the tubes are blocked and dilated? What is it? Correct. Hydrosalpinx. Very good. Okay? What is it? I can see the vagina, cervix, and I can see the uterus. I can't see the tubes. Why? Is cornual block. The cornua are blocked. That is why the dye is not going into tube. So it is cornual block. What is it? What is it? Can I see a single cavity? And can I see a single tube with spillage? Thin one tube. One cavity is laterally divided and one tube. Unicornuate. Okay? Unicornuate. Now question. HSG does help, but the diagnosis of uterine anomalies, the diagnostic method of choice for uterine anomalies is 3D ultrasound. Pehle, remember previously when 3D ultrasound was not there, previously the diagnostic method of choice was laparoscopy and hysteroscopy together, not one of them together, but now it has been replaced by 3D ultrasound. Another thing, Hydrosalpinx bicarbonated block are not anomalies. They are different. They are not uterine anomalies. So whenever there is a tubal block, चाहे वो cornual block हो या fimbrial block हो, whenever there is a tubal block on HSG and you are asked the next step, don't say tubal repair, don't say IVF. The next step is confirming the diagnosis, and you confirm the diagnosis using laparoscopy. So always first confirm the diagnosis. So you first always confirm the diagnosis using laparoscopy. ठीक है? Okay. Now see this image and please tell me what is the diagnosis of this patient. 3 kinds of tubes are present in which illness, in which pathology these types of tubes are present. Who will tell me which pathology has these kind of tubal appearance? This is tuberculosis. When I see the tubes are normal but they are beaded, can you see the beaded tubes are there, beaded? Or tubes are going normally but then they are collecting in fallopian at the fimbrial end, forming a tobacco pouch. Or whole tubes are dilated, hydrosalpinx, typical of tuberculosis. Okay, so genital tuberculosis affect tubes. It affects endometrium and it also affects tube, mainly the ampulla part, totally damaging the mucosa layer. Okay? Now, after doing HSG, let's see some instruments for doing myomectomy. For doing myomectomy, we need these 2 clamps. This is Boney's myomectomy clamp. So when I am doing myomectomy, it's a huge fibroid that I have to remove. I have to make the uterus stable. If the uterus is moving like this, I can't do myomectomy. So this is Boney's myomectomy clamp, which I open and hold the uterus with it, and then I do myomectomy. This is myoma screw. I screw it into the myoma so that it can be pulled out slowly. So this is myoma screw. It looks like a screw, right? So these are used for myomectomy. Okay. Now we have finished the benign disorders. Now we come to the infections. Infections के बाद, I think after infections we are left with pelvic floor. Okay, good, not bad. Let's see the slides of various infections. So can you see the first one? This is normal slide. A slide where I can see gram-positive rod-like bacilli. Can I see gram-positive rod-like bacilli on macroscopic view? This is the one. It is lactobacilli. So this is a normal cell. Now see the second one. It is very granular, as if something is filling it. It's something studded with something. And they are all not gram-positive. See, some are gram-negative and the border is blurred. I can't see the complete border of this epithelial cell. It is so granulated. It is filling that whole margin. I can't appreciate the margins. What is it? This is clue cells. Clue cells seen in case of bacterial vaginosis. So bacterial vaginosis के लिए we need 2 scores for diagnosis. Nugent score कुछ नहीं है, बस we take a sample of the vaginal fluid and we just see it under microscope. We count how many different bacilli are there. Per 1 lactobacilli, how many other bacilli are there, and the score is given. So you don't need to remember the score. Remember, Nugent score is for bacterial vaginosis and another one is Amsel's criteria. The two are for diagnosis of bacterial vaginosis. Bacterial vaginosis is not a sexually transmitted infection. Okay, we treat it using metronidazole, but we don't treat the partner. Next, this strawberry cervix. And when I took the vaginal smear, I can see, can you see the motile organism, the flagellated organisms? Can you see this flagellated organism? It is actually motile flagellated organism. Trichomonas vaginalis. It is a sexually transmitted infection. So here I will treat the partner also. Okay, I'm gonna treat the partner also. It's a sexually transmitted infection. The discharge is typically greenish. Okay? Correct. Very good. if the image is given to me, अरे ये क्या हुआ? What happened to this? Just wait. If this image is given, can you see a curdy, cheesy discharge? And when I did the vaginal smear, when I did the microscopy, I see budding cells. What is it? It is Candida. Trichomonas maybe we give metronidazole, but we treat the partner also. Asymptomatic partner is also treated. This is Candida infection caused by Candida albicans. I can see budding cells, I can see curdy discharge. Only infection where pH is not acidic. Sorry. Only infection where pH is still acidic. In all other infections, the pH becomes alkali, the pH rise. It is the only infection that can flourish even in acidic pH. Okay? What is the treatment? The treatment is fluconazole, oral fluconazole or local antifungal creams. Okay? Now some viral infections. Remember last year में question आया था, तो viral infections में you will see nuclear changes. Can you see the nucleus is so enlarged? On my first look, I can see something is abnormal. Nucleus is not so huge, so nucleus is enlarged. ठीक है? Nucleus is enlarged and it is bilobed. Definitely. It means nuclear changes have started appearing. It is a viral infection. And can you see perinuclear clear halos, big halos around the nucleus? Can you see perinuclear clear halos? So big, dense, enlarged nucleus, clear halos and bilobed. It is a coilocyte caused by infection of HPV. Another viral infection again affecting the nucleus only. Here I will write. It is a coilocyte caused by HPV. Perfect. Very good. Can you see the another one? Here also the nucleus is enlarged. It's a viral infection again. But here the cell are multinuclear. They are not bilobed. They are multinuclear. But important point is inside the nucleus I can see a dark stained body. Inside the nucleus there is something there. Some inclusion bodies. So some inclusion bodies inside the nucleus. Inclusion bodies. So they both look similar. The nucleus are this is bilobed, this is multinucleated, but looks similar. Nucleus is enlarged. But here there are halos, clear halos. Here there is intranuclear clear inclusion bodies. This is herpes. Okay, so this is how you can differentiate between these two. Very important. What is this? Who can tell me? There is some infection that has happened and this kind of smear is seen. What is it? I can see gram-negative intranuclear but diplococci. Gram-negative intranuclear diplococci. What is this? Gonorrhea. Causing pelvic inflammatory disease. Gonorrhea is a sexually transmitted infection. Okay? I'm not going into correct. I'm not going into treatment and of Candida because that will be too much. Sorry, of chlamydia and everything. We are just doing the images. Can you see this one? A swelling just at the vulval opening. This is Bartholin abscess or cyst. Bartholin gland is located on the vulval opening near labia minora. Okay? It is in posterior 1/3 of the vulva. Okay? The treatment for Bartholin cyst is marsupialization. All this has been asked in question. That is why I am saying marsupialization is a treatment for Bartholin abscess. उसका मतलब क्या होता है? Normally cyst में क्या करते हैं? You make a cut and you drain it. But it's a gland secreting. So much mucus is secreted. This cyst will reform. So you make a cut and you evert the margins. This was the cyst. You make a cut and you evert it. इसे हम कहते हैं marsupialization. So that the cyst does not reoccur. Next image. Can you see a retort like, it's not circular, it's a retort like structure with huge, something is filled and it is septated. To me first it looked like hydrosalpinx maybe, but hydrosalpinx is clear fluid. It is septated. A cavity which is septated is generally an abscess. Abscess is forms septa in between. So, and this is retort like. It doesn't look like ovary. It is a pyosalpinx. A tube filled with pus, pyosalpinx. ठीक है? Typical cartwheel appearance. इसको हम बोलते हैं cartwheel appearance. Cartwheel वो देखा है वो, if any of you have seen the बैलगाड़ी, मतलब हमने तो देखा है, बट बैलगाड़ी में जो ऐसा व्हील होता है, कार्टव्हील अपीयरेंस, इसे हम बोलते हैं कार्टव्हील. आई एम श्योर आपको बैलगाड़ी नहीं पता होगा, छोड़ो कार्टव्हील. ठीक है, जेनाइटल अल्सर्स पे आते हैं. ओके, when I see a single ulcer, very defined, hard ulcer, very very hard margin, single ulcer, this ulcer is painless. Lymph nodes are also painless. Syphilis. Syphilis is a clear ulcer which is painless. ठीक है, and the lymph nodes are painless and the margins are hard, इसलिए हम इसको hard sore भी बोलते हैं. ठीक है, it's a hard sore. Syphilis. When I see this ulcer, generally 1 or 2 big ulcer, dirty bleeding base, chancroid. It is a soft margin, so इसको हम कहते हैं soft chancre, soft sore. It's a very soft margins. It is very painful. It is very painful. Another painful ulcer, multiple clear punched out, as if somebody has punched out that skin. Multiple painful ulcers punched out. What is it? Only 2 genital ulcers are painful, herpes and chancroid, and just by looking them you can differentiate. Syphilis is painless. No pain in inguinal lymph nodes, no pain in ulcer. That is why patients don't get themselves treated, and that is why they complicate into the secondary, tertiary and quaternary stage. Because जब तक pain नहीं होता, patient don't get treated and they know it is sexually transmissible. All of them are sexually transmitted infections. ठीक है? Remember, in all of them, I will treat the partner also except herpes. I have explained this multiple times. Herpes में partner को treat नहीं करते. Even if it has come from partner, but in viral illness, treating a partner will not help. Another viral illness, sexually transmitted. It is warts. What is it? Warts, clinically diagnosable. Also called as condyloma acuminata. ठीक है? Condyloma acuminata. Genital warts. So genital warts are caused by human papilloma virus 6 and 11. But remember, certain 10% of warts are also caused by 16-18. So there was a question, a woman has got warts and she has been explained that she has a high risk of cervical cancer. What is the causative organism? When somebody has a high risk of cancer, cervical cancer, obviously it is 16-18. HPV 6-11 does not cause cervical intraepithelial lesions. ठीक है? Warts का treatment बहुत पूछते हैं. Trichloroacetic acid, podophylox, imicomod. These are the chemicals which are used. And also you can remove it using laser. You can also remove using cryo. The importance is how to treat during pregnancy. Pregnancy में the only thing which is best you can use it, remove it using is cryotherapy. Cryotherapy is the best way of treating warts, especially in pregnancy. Other than that, is any chemical can be used during pregnancy, that is TCA. Trichloroacetic acid can be used when pregnant patient gets wart, but not these. Okay. These kits, I hope you remember these kits. So kits ke color you should know. I have entered the image. So if the kit is given, by the color you should know. The grey kit is for cervical discharge, green is for vaginal discharge, white is, so red is for herpetic ulcer. How do I used to remember? If you want to know the mnemonic, see, herpes is painful, very painful, red kit. Vaginal discharge, do you remember a infection causing green discharge, trichomonas? So usse yaad rakho, vaginal discharge can be green because of trichomonas, so green kit. पेट में दर्द, PID, pain abdomen, indicating, हाँ, brown added new, pain abdomen. So P for pain, P for पीला, yellow kit. You can also remember दर्द से लाल पीला होना. लाल is done, so yellow kit. ठीक है. अब आते हैं non-herpetic ulcer. Herpetic ulcer is red. Non-herpetic ulcers, remember ulcers in your mouth, they are of what color? My God, you are ready to remember such a big mnemonic. Grey girl wearing bracelet. I am too bad at remembering mnemonics, so I use small methods. Herpes है तो red color because of pain. Non-herpetic ulcer है तो just like my mouth ulcer, white kit. I am bad at remembering these tongue twisters kind of mnemonics. Anyways, whatever suits you बच्चे, whatever. ठीक है. Then buboes. B for buboes, B for black kit. ठीक है. एनीबडी हु इज पेनिसिलिन रेजिस्टेंट, सी नॉन हर्पेटिक अल्सर में पेनिसिलिन होगा बिकॉज इट इज सिफिलिस. सिफिलिस इज अ नॉन हर्पेटिक अल्सर ना, होगा. बट पेनिसिलिन रेजिस्टेंट को हम क्या देंगे? समबडी हु डज नॉट लाइक पेंसिल, आई विल गिव अ ब्लू पेन, ब्लू किट. नाउ न्यू किट हैज़ बीन एडेड फॉर, सो एनोरेक्टल rectal discharge has gone from here. For rectal discharge, a new kit has been added, and that is a brown kit. That is a new kit added by NACO in 2024. ठीक है. This finishes our infections. Now we come to infertility. Infertility में थोड़ी सी images हैं. What is this cannula? We have just read the HSG. So this is HSG cannula. Leach-Wilkinson cannula. ठीक है. HSG has to be done at around day 10 of menstrual cycle. It is not done in pregnancy or in a abnormal bleeding patient. So this is HSG cannula. What is it? When I am treating a patient for infertility and I am doing IVF, giving ovarian stimulation, sometimes my ovary gets very much stimulated. ठीक है. This is ovarian hyperstimulation syndrome. Hyperstimulated ovaries. Just like theca lutein cyst. Theca lutein cyst look exactly like this. Only difference is by the history. If somebody has just given you the image, you can't differentiate between OHSS and theca lutein cyst. You can differentiate only by the history. One is treated in infertility, another one is pregnant with molar. ठीक है. Pelvic floor disorders. See, pelvic floor disorders में ऐसा मुझे लगता है, I feel that students are very confused about what surgery to be done. ऐसा मुझे लगता है. So besides it's an image based, still I want to explain the pelvic floor disorders surgery. See, this is uterus and this is vagina. So prolapse does not happen only of uterus. Prolapse can happen anywhere. It can happen of vaginal wall, posterior wall and uterus, anywhere. So prolapse can happen of anterior vaginal wall. When anterior wall vaginal wall prolapse happen, we get cystocele. Means the bladder also comes, or urethrocoele. So urethrocoele and cystocele are anterior wall prolapse, and the treatment is anterior colporrhaphy. Colpo मतलब vagina, the pelvic floor. Rhaphy मतलब tighten. So anterior colporrhaphy. Posterior wall when it prolapse, what organ will it bring? पीछे बस एक ही structure है, rectum. Only rectum is behind. So when the posterior wall prolapse, rectum will come along and then it present as rectocele. Rectocele मतलब posterior vaginal wall is weak. So the treatment is posterior colporrhaphy. ठीक है. अब आता है apical prolapse, when the problem of apical ligaments is there. ठीक है. Apical prolapse. Apical prolapse present as two conditions. Remember, uterine prolapse, also enterocele. Enterocele मतलब the bowel is coming. Enterocele bowel is not posterior wall prolapse. Bowel तो होती ही नहीं है posteriorly. Small bowel is in peritoneal cavity, but sometimes through this pouch of Douglas the bowel comes. Posterior wall is intact, rectum is intact. The bowel comes through the pouch of Douglas. So it is an apical prolapse. Enterocele is a apical prolapse, whereas rectocele is a posterior wall prolapse. ठीक है. सो ये दोनों का ट्रीटमेंट हमें समझ में आया. एंटेरोसील का क्या ट्रीटमेंट है? द कल्डी सैक इज वीक, पाउच ऑफ डगलस इज वीक, कल्डी सैक इज वीक. व्हाट विल आई डू? आई विल डू कल्डोप्लास्टी. and let me add the name of the scientist here, McKell. McKell Culdoplasty. I am tightening the cul-de-sac, that is the pouch of Douglas. So McKell Culdoplasty is for enterocele, which is an apical prolapse. The treatment for uterine prolapse originally is remove the uterus, hysterectomy, and tighten the ligaments. But you can't remove uterus in everyone. If family is not complete, then you can't remove uterus. The best is 𝒌𝒄𝒄𝒆. Some places they write it 𝒌𝒄𝒄𝒄𝒉, मतलब cervix से attach कर दो या uterus से attach कर दो. Take a mesh, attach it to the anterior cervical ligament on sacral promontory and then tie it onto the uterus. So uterus will be saved and it will not prolapse. Sacrohysteropexy or sacrocolpopexy. That is the treatment when woman has not completed the family. In somebody who is very fragile, जिसमें any surgery, चाहे वो hysterectomy है, चाहे वो sacrohysteropexy, anything, you can't do. When any surgery can't be done, it is leaf foot in such a very old patient. Stitch the labia, stitch the vagina, and the uterus will not come out. Leaf foot. एक और प्रॉब्लम होती है when it is not prolapse, it is cervical elongation. Uterus is at its place. Due to congenital weakness, the cervix elongates. Generally happen in nulliparous women. Congenitally weak होने की वजह से cervix sag. There, for cervical elongation, you do Fothergill. तो Fothergill is not for uterine prolapse. हर चीज़ का अपना पर्पज़ है. Culdoplasty is for enterocele and sacrohysteropexy and many sling procedures. See, sling procedures have been invented in India. Virchows, Das procedure, they are invented in India. Sling, where you tie uterus to either rectus abdominis and many other places, but they are not very famous. Yes, sling procedures can also be done, but the treatment of choice is sacrohysteropexy. In a very old, you do leaf foot. In cervical elongation, you do Fothergill, where you cut the cervix and tie it. So everything has a different reason. Don't put everything into one basket. Okay? Can I see this image? Where the uterus is taken anteriorly and posteriorly and tied to sacrum. It is sacrohysteropexy. Can you see this one where the cervix is being amputated? Only the cervix, see, everything is in its place, only cervix is coming out. I amputate the cervix and tie the ligaments here. It is Fothergill. Here, the pouch of Douglas is opened like a circle, and using my threads, I'm tightening. I've pushed the bowel back and I'm tightening the pouch of Douglas. This is McKell Culdoplasty. ठीक है? This is what? This is the 3 swab test done for genital fistulas, for urogenital fistulas. The most common cause of urogenital fistula in our country is obstetrical causes, obstructed labor, prolonged labor. In foreign countries, the most common cause of fistulas is hysterectomy. During hysterectomy, the fistula form. We do 3 swab tests for the diagnosis. When I insert 3 swabs and I fill the dye, bladder with methylene blue dye, if the lowermost dye is stained, it is urethral fistula. If the middle dye is stained, middle swab is stained मतलब blue, it is the cysto-vaginal fistula. ठीक है? But when the uppermost is wet, not stained. Why it is not stained? Bhai, whole bladder is filled with dye. Why it is not stained? The urine is coming from somewhere where there is no dye, ureter. So when the swab is not stained, it is ureteric fistula. ठीक है? It can be urethrovaginal, it can be cystovaginal, ठीक है? It can be uretrovaginal. Contraceptives. You have to know certain of the contraceptives. What is this contraceptive? Antara, given by Government of India. At least contraceptives which are given by Government of India free of cost, that you have to know. Antara is a DMPA injection. DMPA injection containing 150 milligram of medroxyprogesterone. It has to be taken every 3 months. A beautiful injection with failure rate of only 0.1%. ठीक है? To be repeated every 3 months. Given IM. A new injection is also slowly coming, not in government plan right now. Yes, Bursch-Kolbo suspension is good. Bursch-Kolbo suspension is done in case of vault prolapse. ठीक है. Transvaginal taping and transobturator taping, TVT or TOT, transobturator taping and transvaginal taping are done for urinary incontinence, and that too which incontinence? Stress incontinence. Stress incontinence is a muscular problem. It's a problem when the sphincter is relaxed. So what do? You pass a tape through the obturator foramen and you tie it with the urethra. So urethra is compressed. So that is the treatment of choice for stress urinary incontinence. Bursch-Kolbo suspension, I'm sorry, Bursch-Kolbo suspension is also for urinary incontinence, but it is not the treatment of choice. Treatment of choice for stress urinary incontinence is TVT and TOT. Either of them. ठीक है. Urge incontinence is basically, urge incontinence is not a sphincter problem. उसको आप सर्जरी से नहीं ठीक कर सकते हो. It is a muscle, detrusal muscle, which is hyperactive. How can you repair it with surgery? So urge continence has to be treated by a medication like oxybutynin, anticholinergics. You give anticholinergics. So urge incontinence medically treated, but stress incontinence treated surgically. ठीक है. Transvaginal or transobturator taping is done. ठीक है. DMPA, right? A new medroxyprogesterone acetate injection is coming called as SynaPress. It is a subcutaneous injection containing 104 milligram of medroxyprogesterone. It will be repeated every 3 months, but it is subcutaneously given. So patient can take it herself. Good thing about SynaPress is there is no need of fridge, whereas Antara has to be refrigerated. Here patient can take it herself. Patient does not need to go to the doctor to take SynaPress. So SynaPress is a subcutaneous injection. ठीक है. What is this? This is an implant. Implant is the contraceptive which has the least failure rate, 0.01%. It is better even than permanent methods. ठीक है. Implant has a validity. It contains mainly etonorgestrel and it has a validity of almost 3 years. Chaya is another contraceptive included in our family planning program. It is a non-steroidal contraceptive, ormiloxifene. It has been made in India. So ormiloxifene. पहले सहेली नाम से आता था, but now it is known by name of ormiloxifene. इसे once a week pill भी कहते हैं, because it has to be taken only once a week. So it's a routine contraceptive not containing steroid and has to be taken only once a week. IUCDs. This is Lippes loop, generation 1, inert, copper containing IUCD. So this one is copper T380A. ठीक है. And this one is third generation containing hormones, Mirena. Mirena contain levonorgestrel released at rate of 20 mcg per day. Which contraceptive has the highest lifespan? This one, 10 years. This one has to be removed after every 5 years. ठीक है. Contraceptive, when it can be inserted? This is very important. Postpartum में contraceptive can be inserted up till how many days? Either immediate post placental insert करना है, immediate, or within 48 hours. If somebody has refused to get inserted within 48 hours, now you can't insert. Now you can insert only after 6 weeks. On what menstrual cycle should a contraceptive be inserted? On what day? Any day. Contraceptive can be inserted on any day of menstrual cycle, unlike OCPs. OCPs should be started from day 1 to day 5, but these can be inserted any day. As soon as you insert, they are effective. ठीक है. Permanent method is where you ligate the female fallopian tubes. The part which is ligated is isthmus, because isthmus is a very regular part, very uniform diameter. So that is why ligation is done at isthmo-isthmic junction. There are many methods that can be used, but what is used commonly is modified Pomeroy's. Modified Pomeroy's is used, and what we use is plain catgut. Plain catgut is used for ligating a fallopian tube. Fallopian tube ligation is done using this forceps. Can you see this? Babcock's. Babcock's is used as an atraumatic forceps. It has no teeth. Okay, but can you see the shape is like that, as if you are trying to hold a tubal structure. है ना? ऐसे देखो, it is not like this, flat नहीं है. इसको जानबूझ के they have made it deliberately like this so that tubal structures can be held, like fallopian tube, like appendix. So Babcock's forceps is used to hold tubal structures. Clips में भी आ रहे हैं बच्चे. So these are Babcock's forceps used for tubal ligation. Now there are many ways, other ways of doing tubal ligation. One is laparotomy. While doing laparotomy, you can do modified pomeroys. Another one is hysteroscopically. Hysteroscopically, you insert a 𝒆𝒅. 𝒆𝒅 is a titanium containing spring. You insert the 𝒆𝒅 inside the tubal cavity. There is so much inflammation that the tubes block. So this is a hysteroscopic tubal occlusion. ये ligation नहीं है. Ligation means बांधना, tie something. It is occlusion. You have occluded the cavity. Using 𝒆𝒅, you have occluded it. Laparoscopically also it can be done. Now you don't need to do laparotomy. Laparoscopically it can be ligated, but laparoscopically you can't do pomeroys. Pomeroys में तो पूरा tie करना पड़ता है. How will you do it laparoscopically? So laparoscopically you use this. You use Filshie clips. Either Filshie clips or 𝒂𝒂𝒂𝒉 clips, or most commonly the silastic rings, ऐसे fallope rings कहते हैं. Fallope rings. These rings are inserted inside and we cover the tube with these rings. ठीक है? So these rings can be used. Also you can cauterize or burn the tube. So laparoscopically, by these ways the tubes are ligated. So in a family planning, we have a basket of contraceptive. A whole basket of contraceptive is available, where the contraceptives are available free of choice in government hospital. What are they? Basically, the contraceptives we have is levonorgestrel mala N. Okay, that is available free of cost. What is the content here? What is the content of mala N? LNJ is 150 mcg. Ethinyl estradiol is 30 mcg. ठीक है? Levonorgestrel tablet emergency contraceptive pill, where it is 1.5 milligram levonorgestrel pill is there. ठीक है? Easy pill. So it is all available free of cost. So you have to know about them. छाया हमने पढ़ा है अभी. It is non-steroidal ormeloxifene. Ormeloxifene क्या होता है? Selective estrogen receptor modulator. Once a week pill. Copper T 380A and multi-load Copper T 375, they are available free of cost. Antara contraceptive IM injection is available free of cost, and condom. So these 7 methods are there in a family planning basket of ours. ठीक है? इनके बारे में you have to know all the details. ठीक है? Finish. Now last we are doing oncology. Oncology में you identify what is this? Yes, in the mala N, 21 tablets are hormonal, 7 tablets are non-hormonal, and they are, what have you written? Ferrous what? They are ferrous sulfate. ठीक है? So mala N में 7 tablets are non-hormonal, ferrous sulfate. ठीक है? चलो, screening of cervical cancer. Do you know what is this? Iron spatula and brush. We take the sample and we paint it onto the slide and we see the cells. ठीक है? What is the preservative that is used? Ethanol. Ethanol is the preservative that is used. 95% ethanol. ठीक है? Another method of cervical cancer screening. Those who don't have lab, there we use visual inspection. ठीक है? नहीं, ferrous sulfate, not fumarate. Ferrous sulfate is there. So using our visual inspection, either apply the acetic acid, visual inspection with acetic acid, or visual inspection with Lugol's iodine. The cancerous abnormal cells turn snowy white, and here the abnormal cells don't take up the stain, and you can take the biopsy. Tell me the age of, now you have to tell me this, age of screening, the primary test which is now done for screening, and how often it is repeated. Please answer these questions. You can't go to NEET exam without knowing these. Tell me, what is the age of screening? What is the primary test for screening? All of you. See, starting the age of screening कोई range तो हो ही नहीं सकती. When do you start? I mean, how can it has to be a specific range when I'll start screening. It cannot be a range, either 9, either no. At what age the screening should be started? What is the primary test? And how often should it be repeated? Okay. And I need the updated version, updated screening guidelines. When it should be started? I want to see how updated you are, because at many places the guidelines of screening have not, at many books they have not been changed, but actually they have been changed 2 years back. The age of screening is 25 years, not 21 anymore. The primary test for screening is HPV detection using cytobrush, and it is repeated every 5 years. Those who don't have HPV DNA detection, there we use pap smear, and pap smear when done it is repeated 3 yearly. HPV if done it is repeated 5 yearly. In very rural areas, there are no HPV, no pap smear. There we use 𝑭𝒂𝒑 in rural areas. 𝑭𝒂𝒑, if that is the screening method, that is started at 30 years. As such, the age of screening is 25 with HPV detection. It has to be updated. American Cervical Cancer Society has updated in 2022. ठीक है? Please write it down somewhere. What is this? This is the chemotherapy given, the tandem and the ovoid chemotherapy given in case of cervical cancer, where these ovoids or sometimes colpostats are inserted near the cervix to deliver the radiations. These are used. When you are delivering the radiation, the harm to the peripheral tissue should be taken care of. So we have created an arbitrary point, A and B. These are arbitrary point. A point is internal ostium 3 cm, 2 cm above, 2 cm far is A point. उससे भी 3 cm far more is B point. So A point is the place where uterine artery is crossing the ureter. Point B is considered to be the point of obturator lymph node. ठीक है? These are the points through which we measure how much radiation is reaching these points. We have to take care. Radiation should not be more than 7,000 GY in A point A and more than 6,000 in point B. This much radiation should reach in point A and B. Yes, this is a type of brachytherapy. Brachytherapy means radiation is delivered just close to the cancer origin. So can you see the colpostats are on to the cervix? So it is not an external beam radiation. External beam radiation बाहर से देते हैं. It is a brachytherapy. ठीक है? Done in cancer cervix. Okay. Some images of ovarian cancer. Can you see the coffee bean appearance in the cells? Inside the cells, can you see these coffee bean like nuclei? Indentations are there, turning these nucleus into coffee bean like, isn't it? And how the cells are arranged peripherally in a flower pattern. So Kohl-Exner bodies and coffee bean appearance is seen in which cancer? Which ovarian cancer? Granulosa cell tumor. And this, can you see intracellular calcification, the rings of calcification? Psammoma bodies. Psammoma bodies are typically seen in serous cyst adenoma. ठीक है? बाकी our details of ovarian cancer I am not discussing. We are just discussing the images. What is this? A bosselated, yellowish bosselated tumors. Bosselated yellowish tumor. Dysgerminoma. Dysgerminoma is this yellowish tanned. When you will do a cut section, yellowish tanned appearance is dysgerminoma. ठीक है. Unilocular cystic, very smooth shining surface, serous. You can be asked about these images. Huge tumor filling the whole abdominal cavity. Huge tumor, multiple cavities and loculi are there. Mucinous. The tumor marker for serous is mainly CA125. It is the most common ovarian tumor that happen. It is an epithelial tumor. Mucinous is second most common. The tumor marker is CEA. When the image is given where many other tissues are present, fat is seen, hair are seen, some bony tissue are seen, multiple tissues are seen, it is teratoma. Teratoma, if teratoma is benign, we call it dermoid cyst. If teratoma is immature, we call it immature teratoma. ठीक है. So benign teratoma is called as dermoid cyst. ठीक है. Now you want me to go through the partogram, right? So whatever possible images were there, we have discussed them. Now I want you to discuss about partogram. Just give me a second. Here it is. ठीक, चलो. See, partogram is a graphical representation of many things. Fetal information, maternal information and progress of labor. So it is not just progress of labor that is being plotted. Fetal information, maternal information and progress of labor, all of them are being plotted. ठीक है. So one part is about fetus. So where you point out the fetal heart. So fetal heart is measured in second stage of labor every 30 minutes, right? Pritchard regime done. Okay, just after that. So fetal heart should be between 110 to 160. इसमें गलत plotted है. It is 110 to 160. ठीक है. It is plotted every 30 minutes in a low risk woman, every 15 minutes in a high risk woman, and we plot the fetal heart. Also, we mention about the amniotic fluid. It is clear. It is blood stained. It is meconium stained. Molding means the overlapping of scalp. If scalp is coming together, joint touching each other, it is one. As the scalp should be little away. If they are overlapping but slipping back, overlapping, slipping back, grade 2. Overlapping and not slipping back, grade 3. Whenever your question has given, if your question has given grade 3, it has indicated that it is CPD. It has indicated that vaginal delivery will not happen. So whenever you see plottogram, don't see only progress of labor, see everything. How fetal heart is doing, amniotic fluid meconium stained to nahi hai, see everything. Molding 3+ to nahi hai. In your last year question, it was written 3+. Means the baby will not deliver vaginally. Please do a cesarean. Itna overlapping ho gaya means baby is trying to enter in pelvis but not able to. ठीक है. Maternal information में there is pulse and blood pressure. Pulse taken every 30 minutes, BP taken every 4 hours, also temperature and everything. Then comes the uterine contractions. Uterine contractions may the number of boxes you color. If I color 3 boxes, 1, 2 and 3, that indicates how many contractions are coming in 10 minutes. ठीक है. Sorry, how many contractions are coming in 1 minute. So you keep your hand there for 1 minute and you count the number of contractions. So how many contractions in coming in 10 minutes, then that are told to you by number of boxes I am coloring. So one is number of contractions, ठीक है. Other is intensity. If it's a good intensity contraction, ठीक है, I will completely color the box. 3 contractions, good intensity. Good intensity मतलब persisting for 40 seconds. Persisting for 20 to 40 seconds means going very fast. I will make lines. Weak contractions coming and going within 20 seconds. I'll make dot. So whenever you are reading partogram, just see what kind of contractions are there. Don't just see, suppose progress of labor is slow. Don't mark oxytocin. Suppose niche contractions are like this. They have colored 4 boxes. What are good contractions? 3 to 4 contractions of good intensity of more than 40 seconds. 4 contractions of good intensity hain. Why will you start oxytocin? So always see what kind of contractions are plotted on the partogram. Then only you will start oxytocin. Now comes the very important part, cervicograph. Cervicograph is that part where we plot the progress of labor. Important thing, partogram plotting is started only at 4 centimeter, though now active phase is started at 5 centimeter. So अब एक न्यू पार्टोग्राम भी आ गया है, अगर आपको पता हो, लेबर केयर गाइड. लेबर केयर गाइड इज द न्यू पार्टोग्राम विच स्टार्ट्स एट 5 सेंटीमीटर. दिस इज़ द ओल्डर वन जो हम पढ़ रहे हैं, जिसपे सबसे ज़्यादा क्वेश्चंस आए हैं. दिस इज़ द ओल्डर वन. इसको हम बोलते हैं मॉडिफाइड पार्टोग्राम. नाम मॉडिफाइड पार्टोग्राम है, बट इट इज़ ओल्डर वन. न्यूअर वन इज़ लेबर केयर गाइड. So modified partogram plotting starts at 4 centimeter. It has 2 lines, alert action lines separated by 4 hours. Where is the first plot made? Always remember, patient comes to me at 6 centimeter. My first plot will be here, on the alert line. I don't plot from here, no. Why I'm to the left of alert line? Why am I giving this advantage to the patient? No. My first plot is always on the alert line. Patient आती है 8 centimeter पे, my plotting is here. From here I'll start plotting 12 p.m. So first plot is on the alert line. And you plot every 4 hours, maybe faster than that, that's not a rule. As soon as the plot is slow, as soon as the rate is little bit slow, it should be 1 centimeter per hour. If it is slow, it will cross the alert line. Abhi tak I was on alert line. If it is slow, alert line is crossed. Alert line crossed means now you have to see what is the what has happened. So why it is slow. So what will you do? You rule out CPD. See whether the molding is 3 plus, 2 plus or 1 plus. Start oxytocin if no good contractions. Oxytocin is only started when there are no good contractions. And then you repeat your PV after 4 hours. After 4 hours, if it is still slow, it will touch the action line. So it will touch. If it touches the action line, now you have to deliver. Whether via LSCS or via instrumental delivery, that you have to see. But as soon as it touch the action line, you have to deliver. We will see कि LSCS करते हैं या instrumental delivery करते हैं. So once it cross the alert line, you become alert, shift her to a better center, start oxytocin, rule out CPD. But as it touch the action line, you have to deliver the baby now. How will you deliver the baby? See. If they have specially shown that some patient was at 5, then it crossed the alert line and now it is at here. This is the graph which has been shown. Molding suppose nahi bhi di hai. Now this is the time you have to deliver. How will you deliver? See, this is 8 centimeter. 8 centimeter pe I can't apply instrument. So when the cervix is not fully dilated and when the molding is 3 plus, I know I have to do LSCS. Suppose the graph shows alert line is touched but it is 10 centimeter. Slow है but 10 centimeter पे आ चुका है. Head is also deep in pelvis. Then my answer will be instrumental delivery. So always see at what centimeter it is. I can't apply instrument in 8 centimeter. What about fetal head? Fetal head is palpated, is plotted here. How many parts of fetal head are palpated per abdomen? Pelvis में baby is entering. Some part of baby is in the head, in the pelvis, some part of the baby is in abdomen. How many parts are palpable per abdomen? Baby's head is divided into 5 parts. How many parts I can palpate in abdomen? That is plotted here. 3 parts are plotted, 3 parts are palpated. मतलब pelvis में वो थोड़ा सा ही गया है. Only 2 parts have gone in the pelvis. I can palpate only 1 part in the abdomen. Means 4 parts of the head are gone into the pelvis. So 1/5 or 0/5 means मेरे को I can't palpate any fetal part in the abdomen. Means head is engaged. So see where the head is. अगर आपका head 3/5 है, 2/5 है, यहाँ पे भी 2/5 है. You can't apply instrument. For applying instrument, head should be engaged. And engaged means per abdomen में I can feel either one part of the head, इस पूरे head का only one part is felt or none of the part is felt. That means head is engaged. So before writing how will I deliver, see molding, see the dilation and see the descent of head. Simple. ठीक है. You want to know about Pritchard regime. Let me explain you there only in the here, so that once you get the PDF you can revise. Pritchard regime is the IM regime for giving mag self. ठीक है, जैसे ही पेशेंट आता है आई हैव टू गिव अ लोडिंग डोज. मेंटेनेंस डोज तो बाद में देंगे. आई हैव टू गिव अ लोडिंग डोज. लोडिंग डोज इज 14 grams. रिमेंबर इट इज़ इन ग्राम्स. इसमें से 4 ग्राम आई हैव टू गिव IV एंड 10 ग्राम आई हैव टू गिव IM. डाइल्यूशन इज 20% एंड 50%. ठीक है, अब कैसे बनाते हैं? जो मैक्स सेल्फ का वायल है, मैक्स सेल्फ वायल इज़ अ 2 ml वायल. ये 2 ml का वायल होता है. In this 2 ml vial, only 1 gram is max self. So in this 2 ml of fluid, 1 gram is max self. So how much dilution is there? It is already in 50% dilution. The vial is in 50% dilution already. ठीक है, in 2 ml of fluid, only 1 ml or 1 gram is max self. So it is in 50% dilution. So it means जो मुझे IM देना है, I don't need to dilute. ठीक है, अगर 10 ग्राम देना है, I will open 10 ampules. ठीक है, 10 ampules को ओपन किया. आई विल लोड इट इन डिफरेंट सिरिंजेस. 10 ampules मतलब 20 ml. तो इससे बेटर है आई विल लोड इट इन डिफरेंट सिरिंज. 10 ml इन वन सिरिंज, 10 ml इन वन सिरिंज. 10 ampules मतलब 20 ml ना. एक एम्प्यूल इज़ 2 ml. सो 10 ml एंड 10 ml अनडाइल्यूटेड है, दे आर अनडाइल्यूटेड. सो 10 ml यहाँ पे कितना हुआ? 5 ग्राम. 5 ग्राम I will सीधा give in each बटक. Problem is this IV. How to make it 20%? I will 4 gram मतलब how many ampules will I need? 4 ampules मतलब how many ampules I will need? 4 gram मतलब 1 ampule has 1 gram. I will open 4 ampules. 4 ampules मतलब कितने ml हो गए मेरे पास? 2 ml का है ना एक ampule. 1 ampule is 2 ml. It means 8 ml. I will load it in 20 ml syringe. 20 ml में if I have taken 4 ampules, it is 8 ml. 8 ml का हो गया. Remaining 12 ml, I will fill it with distilled water. I'll fill it with distilled water and now this 20 ml, if you will calculate, is in 20% dilution. जब पेशेंट आता है कन्वर्स करते हुए, इतना टाइम थोड़ी होता है हमारे पास. We don't have that time. It is at spinal level. We open 10 ampules, load it in 2 syringe, give IM. Open 4 ampules, load it in 20 ml syringe. 20 ml में 8 ml max self रहेगा, 12 ml distilled water रहेगा. Distilled water नहीं है तो saline. That will be 20%. Give it slow IV. Simple. When every 4 hour the patient comes, that is the continuation dose. Every 4 hour आपको maintain रखना है max self का level. If you will not maintain, patient will throw conversion. So maintenance level is by giving 5 gram undiluted IM. हर बार 5 ग्राम मतलब 5 ampules लो, 5 ampule मतलब 10 ml लो, बटक में लगा दो every 4 hours. सिंपल. ठीक है, ओके. अच्छा, मतलब यार तुम लोग इमेज बेस्ड में कोई प्रॉब्लम नहीं है, बट देर इज़ अ लिटिल एक्सटेंशन ऑफ गोइंग ऑन. सो दोज हु वांट टू गो, वी हैव फिनिश्ड विद द इमेज बेस्ड सेशन, दे कैन गो. दोज हु वांट टू स्टे एंड आस्क फ्यू क्वेश्चंस, दे कैन स्टे, नॉट एन इशू. ठीक है, सो डू वेरी वेल. एग्जाम इज़ कमिंग अप. स्ट्रेस होगा सबको और होना भी चाहिए. जिसको स्ट्रेस नहीं हो रहा है, दैट इज़ अ प्रॉब्लम. इन सच अ बिग एग्जाम, सच एन इंपॉर्टेंट एग्जाम, देयर शुड बी स्ट्रेस, बट स्ट्रेस को मैनेज करना आना चाहिए बच्चे. दिस स्ट्रेस इज़ वेरी लिटिल. अभी PG में जाओगे ना, यू विल हैव ह्यूज स्ट्रेस. ठीक है, वहाँ पे सब लोग परेशान करते हैं. पीपल टीज यू फॉर नो रीज़न. आपको समझ भी नहीं आएगा वाई दे डिसलाइक यू, बट दे विल डिसलाइक यू. द रीज़न इज़ दे डोंट डिसलाइक यू, दे आर फ्रस्ट्रेटेड विद देयर ओन लाइफ. प्रोफेसर, सीनियर्स, एवरीवन. सो मेक योर सेल्फ स्ट्रॉन्ग. दिस इज़ द टाइम. दिस इज़ द टाइम. मेक योर सेल्फ स्ट्रॉन्ग मेंटली. ठीक है, कुछ भी हो जाएंगे, वी विल हैंडल एवरीथिंग. ठीक है, कुछ भी हो जाएंगे, अपने आप को हार्म नहीं करने वाले हैं. वी आर नॉट गोना हार्म आवरसेल्व्स. बिल्कुल भी अपने आप को हार्म नहीं करना है. सो अभी स्ट्रेस हो रहा है, उसको मैनेज करना सीखो. एवरीवन हैज़ देयर ओन वे. व्हेन आई गेट स्ट्रेस, आई प्ले गेम. सो आई प्ले. सम पीपल लाइक डांसिंग, सम पीपल मेडिटेट. यूज़ योर वे. सम पीपल हैव कॉफ़ी, बट बी अ वेरी स्ट्रॉन्ग पर्सन. ठीक है, इस दुनिया में ना स्ट्रॉन्ग के अलावा कोई ऑप्शन नहीं है. यू हैव टू बी स्ट्रॉन्ग बच्चे. वीक रह के देयर इज़ नो ऑप्शन. सो प्रिपेयर, गुड लक, एंड दोज हु वांट टू लीव दे कैन गो. ओवेरियन सिस्ट मैनेजमेंट. सी ओवेरियन सिस्ट के लिए वाई आर वी सीरियस? बिकॉज वी डाउट दैट दिस ओवेरियन सिस्ट कैन बी ओवेरियन कैंसर, है ना. चांसेस ऑफ बीइंग ओवेरियन कैंसर इन अ प्री मेनोपॉजल इज लेस है, बट लेस है. मीनोपॉजल में सिस्ट नहीं दिखने चाहिए. इफ अ सिस्ट इज देयर इन मीनोपॉजल देयर आर चांसेस इट माइट बी कैंसर. सो मैनेजमेंट इज डिफरेंट. इन प्री मेनोपॉजल if I see an ovarian cyst, I have to see whether it is simple. Simple matlab like a balloon. No septation, no fluid, simple cyst. If it's a simple cyst, I can manage it conservatively till 8 centimeter. 8 centimeter का cyst I can manage conservatively. So I will mainly give her OCPs and I will see the cyst will resolve. ठीक है, cyst will resolve. But if it's a huge cyst, it is a big cyst. Cyst should not be that big. Then I will go for tumor markers. Similarly, if the cyst is a complex cyst, it has internal septations, it is bilateral. एग्ज़ाम अभी मैं बात करती हूँ आपसे, क्यों नहीं होगा एग्ज़ाम में? ठीक है, मे बी होगा तो है ही, है ना. इफ़ यू हैव वर्कड होगा तो है ही. मे बी यू विल नॉट गेट अ रैंक ऑफ योर चॉइस. ठीक है. सी important is if you are a strong person ना, you will make best out of whatever you have done. You have seen your faculty. आपको लगता है कि जिन्होंने मे बी anatomy उठाया या physiology उठाया, they are less happy and they are not earning well. They are earning beautiful and they are extremely happy. The thing is they are very hardworking compared to other people. Somebody might be surgeon, not earning at all, frustrated with his life. The thing is he is not hardworking. He doesn't know how to handle stress. So it doesn't matter what you get. Important is work hard. Guilt नहीं होना चाहिए कि मैंने मेहनत नहीं की थी. If you don't have that guilt ना, फिर आपकी जो भी रैंक आएगी you will do beautiful. That guilt is the one that make people frustrated and that make people destroy their life. Don't be in guilt. So बस मेहनत करो, guilt नहीं होना चाहिए. फिर तो जो रैंक आएगी, if you are not in guilt, you are happy with your performance, you will do wonders in that branch, whatever the branch is. Okay? If the cyst is big or it is a complex cyst, now I am worried about cancer. So in a premenopausal woman, I will do tumor markers. So what cancer can happen in a premenopausal? Epithelial हो सकता है, I'll do CA125. Mucinous हो सकता है, I'll do CEA. But there are other chances like a germ cell tumors. Germ cell tumors are more common, isn't it, in premenopausal? तो germ cell tumor के markers क्या हैं? इनहिबिन कर सकते हैं वो ग्रैनुलोसा सेल स्ट्रोमल सेल ट्यूमर के, है ना. सो LDH अल्फा फीटोप्रोटीन इनहिबिन. सो ट्यूमर मार्कर्स विल बी डन फॉर जर्म सेल ट्यूमर्स एंड एपिथेलियल बोथ. एंड इफ द ट्यूमर मार्कर्स आर हाई, नाउ मोस्ट लाइकली इट इज़ कैंसर. बिफोर गोइंग फॉर सर्जरी आई ऑलवेज डू द CT स्कैन. CT स्कैन इसलिए देखते हैं कि कितना हाउ द कैंसर हैज़ स्प्रेड, सो दैट आई डिसाइड माई एरिया ऑफ लेप्रोटमी. ट्रीटमेंट क्या होता है ओवेरियन कैंसर का? इट्स नॉट ओफोरेक्टमी, इट इज़ नॉट हिस्टेरेक्टमी, इट इज़ डीबल्किंग सर्जरी. रिमूव एवरी बल्क यू सी, रिमूव एवरी सस्पिशियस कैंसर यू सी, एंड देन डू कीमोथेरेपी. सो द ट्रीटमेंट इज डीबल्किंग एंड डूइंग कीमोथेरेपी. इट इज़ नॉट ओफोरेक्टमी और हिस्टेरेक्टमी. नहीं, सब कुछ हटा दो जो सस्पिशियस है. ओमेंटम, असाइटिस, ब्लैडर, पेरिटोनियल, एवरीथिंग विच इज सस्पिशियस. ठीक. सो दिस इज हाउ यू मैनेज अ प्री मेनोपॉजल वुमेन. मेनोपॉजल में the chances of being a cancer are higher. ठीक है, there are more chances that most likely it is a cancerous tissue. So how you manage in post menopausal? वहाँ पे तो we waited. cyst जब तक 8 सेंटीमीटर की नहीं थी we waited. post menopausal में any cyst, simple or complex, I don't care. Whatever the cyst is, I do CA125 in everyone. LDH alpha fetoprotein I will not do, because germ cell tumors don't happen in postmenopausal. So I will do CA125. ठीक है, CA125 करा and I calculate a score जिसे कहते हैं RMI score, risk of malignancy index. Don't remember that, just remember RMI more than 2. RMI में क्या चीज़ें लेते हैं? The score includes 3 things: age, level of CA125 and ultrasound. These 3 things are taken. If the score is more than 200, it is cancer. It is cancer. Again do the CT scan and go for debulking surgery या staging laparotomy. एक ही बात है. ठीक है. बट इफ द स्कोर इज लेस देन 200, अब इफ द स्कोर इज लेस देन 200, नाउ लुक एट द सिस्ट. ठीक है, स्कोर आपका कम आ गया. तो इफ द सिस्ट इज लेस देन 5 सेंटीमीटर, कुछ मत करो, जस्ट कीप ऑन मॉनिटरिंग इट. देखो कि बढ़ तो नहीं रहा है. बट इफ द सिस्ट इज मोर देन 5 सेंटीमीटर और इट इज़ अ कॉम्प्लेक्स सिस्ट. ठीक है, यहाँ पे था सिंपल सिस्ट, यहाँ पे था कॉम्प्लेक्स सिस्ट. बड़ी सिस्ट है या कॉम्प्लेक्स है, इन बोथ दीज केसेस ओफोरेक्टमी कर दो. डोंट डू डीबल्किंग सर्जरी, कीमो नहीं. इट इज़ नॉट कैंसर. कैंसर होता तो RMI ज़्यादा होता. रिमूव द ओवरीज. बायलेटरल मेनोपॉजल है, कोई फ़र्क नहीं पड़ता. सो कॉम्प्लेक्स सिस्ट and big simple cyst is removed in postmenopausal if CA-125 is less. If CA-125 is high, it is cancer. Do the CT scan. In perimenopausal, पहली बात, अगर simple cyst है तो कुछ मत करो. Simple cyst is common unless it is big. But अगर complex cyst है या फिर big simple cyst है, do the tumor markers. And tumor markers is not only CA-125, LDH, HCG, alpha fetoprotein also. And then decide. ठीक है, रिमेंबर पोस्ट मेनोपॉजल में सिर्फ CA-125 करने की ज़रूरत है और कुछ नहीं. ठीक है, आई थिंक टुडे सेशन इज डन. वी आर डन फॉर टुडे. ओके, सो वट एवर एनी मोर डाउट्स यू हैव, यू नो माई इंस्टाग्राम चैनल. यू कैन ऑलवेज पुट योर डाउट्स. आई ऑलवेज रिप्लाई ऑन दोज चैनल्स. एंड ठीक है, मिलते हैं फिर. डू वेरी वेल, है ना. बहुत अच्छा करोगे यार, अच्छा करो. बस मेंटेन योर हेल्थ, मेंटेन योर मेंटल सैनिटी एंड डोंट हार्म योर सेल्फ नो मैटर वॉट. आजकल देख के ना आई एम वेरी स्कैर्ड. सो बेटा सबके साथ प्रॉब्लम होगी. आपको क्या लगता है कि वी हैव नॉट फेल्ड? आई हैव फेल्ड. आई हैव गॉट बैड रैंक्स इवन आफ्टर गेटिंग गुड सिलेक्शंस. देन ऑल्सो हैव बीन harassed mentally and by doing not what not. But it made me a very strong person. I never try to harm myself. Why? Because remember, if you harm yourself, किसी घंटा दुनिया को फ़र्क नहीं पड़ता. Only person that will be affected is your parents. So if you don't want to affect your parents, be a strong person. Be a very strong person. ठीक है, चलो, okay.